السلام عليكم جميعا. My name is Khalid Al-Dahmani. I'm adult endocrinologist at Tewam Hospital, United Arab Emirates, and I'm the president of Gulf Association of Endocrinology and Diabetes. I'd like to welcome you all to our 7th Gulf Endocrine Review course. And today is the second day of the course. The course has a CME hours attached to it. So after the course, you need to fill a survey, and then you will receive the CME hours certificate with that. For today, we have the first session is a pituitary disorders session, and the second session will be male reproductive disorders. Then we move to lipids disorder, and then we end with type 1 diabetes session. So please note the change as lipids disorders moved to day 2 rather than day 3, and obesity moved to day 3. It's my pleasure to introduce the first speaker. Is a Professor Roberto Salvatori. He is a professor of medicine and neurosurgery at Johns Hopkins University. He is also the medical director of Pituitary Center. He has more than 170 publications. He is invited speaker in national and international conferences. In fact, he joined us as a speaker in GAID when it was conducted in Riyadh 2 years back. Professor, you can start your presentation.
Well, thank you very much for the invitation, and thank you very much for the kind introduction. It's a pleasure for me to be here today, although just virtually. And this is a great program, and I actually am going to recommend it to our fellows because this is a great course that even our endocrine fellows would probably benefit from. So I have a series of questions today. The discussion will be at the end for questions, and we're going to go straight to the first question. This is a 38-year-old woman who had a history of infertility, who is referred to you for evaluation of a possible hypercortisolism. She has noted a weight gain of about 10 kilograms over the past year, some tiredness, some insomnia, and some body hair growth. At this time, she's only on birth control pill, and her GYN doctor has already thought about hypercortisolism and has obtained a 24-hour urine-free cortisol, which was mildly elevated at 55, maximum in the 24-hour with normal value below 45, a random CTH of 28 picogram per ml, and he has already performed a 1 milligram dexamethasone suppression test with a morning cortisol after weaning dexamethasone in the following morning of 3.9 microgram per deciliter. And I think you in the Gulf use a nanomole per liter, so this will be 107 nanomole per liter. On exam, she's borderline hypertensive and she is obese with a BMI of 37, is centripetal obesity and some hair growth in the infraumbilical area. She has pale abdominal stria. So the question is, what should be the next appropriate step in the workup of this lady? A, obtain a pituitary MRI. B, order an adrenal CT. C, repeated dexamethasone suppression test with 2 milligrams. And D, obtain bedtime salivary cortisols. And just for the technical people, we should wait until all the attendee can read all the answers before putting the pooling method. Anyhow, the D is obtain bedtime salivary cortisol, and C is repeat dexamethasone with 2 milligrams. Okay, so the majority of people wrote obtain bedtime salivary cortisol. Somebody ordered a pituitary MRI, somebody an adrenal CT, and very few repeat dexamethasone suppression tests with 2 milligrams. So this is the asterisk. Great, thanks. That shows what the right answer is. Obtain bedtime salivary cortisol level. Okay, why? So as you guys know very well, the diagnosis of Cushing syndrome is sometimes obvious, but sometimes very challenging. The 24-hour urine-free cortisol is not a very specific test, particularly if it is only mildly to moderately elevated. It can be increasing depression, obesity, and anxiety. And the most sensitive test to diagnose Cushing is the dex suppression test with a cutoff of 1.8 microgram per deciliter, which is 50 nanomole per liter. However, in the workup, there are a lot of wrinkles, and you must be aware of a possible false positive and false negative test. And the two most frequent causes of a false positive test are use of oral estrogen. The oral estrogen increase cortisol binding globulin, as occur in this case. And therefore, you can have a falsely abnormal dexamethasone suppression test. So if a woman suppresses while on estrogen, then Cushing is ruled out. But she doesn't suppress, then you have to repeat it off the birth control pill for about a month. And the other possible cause of false positivity, if a patient is on a medication and increases catabolism of dexamethasone, typically anti-seizure medications such as dilantin or carbamazepine, or TB medication like rifampin. So because of this, it's important always to measure dexamethasone level when you do a dexamethasone suppression test to make sure that you reach suppressible level. In most assays of 100, 120, 130 nanograms per deciliter. But in this case, the test was likely abnormal because the patient was on oral estrogen. And salivary cortisol, however, is a reflection of free serum cortisol and is not affected by CBG. So in this patient, you had two options. One, to ask her to stop the birth control pill for a month and repeat the dexamethasone suppression test. And the other option was to obtain salivary cortisol. The first option was not offered, so the right answer was obtain salivary cortisol at bedtime. So ordering a pituitary MRI is never a good idea in patients unless you have a biochemical diagnosis. And the reason is that about 10% of people, and we'll go over this later in the lecture, have pituitary incidentalomas. And so having an abnormal DEX suppression test plus an incidentaloma may lead your neurosurgeon to operate on a patient who actually does not have Cushing. So this is a flow chart that was presented in the recent consensus statement that we as Pituitary Society published in 2021 in Lancet Diabetes Endocrinology. I think is a very good review. And as you can see here, it's a rather complicated algorithm, and there is a second part. But the first part is, does the patient have hypercortisol? Does the patient have Cushing syndrome? And you should not really go to the second step unless you know for sure that the patient does have hypercortisolism. So how do you screen? You can screen with a late night salivary cortisol, 24-hour urine cortisol, and overnight dexamethasone suppression test. Okay, so if they are all abnormal, then of course the patient has likely hypercortisolism. But there is a lot of wrinkles in these, and sometimes patients have one abnormal, one normal test, and you'll have to learn how to use this test in a very astute way, because they can throw, wrinkle. And one last wrinkle that can be seen, although very rarely, is for patients who have cyclical Cushing, where tests are intermittently abnormal and intermittently normal. And of course, as you can imagine, the diagnosis is very difficult to nail, just because of the very nature of the cyclicity, which is totally unpredictable. The periods between cycle can be variable, weeks, months. Of course, you have to consider the presence of psychiatric disorders such as severe depression, alcohol use, severe obesity, and of course, use of birth control pill, as we discussed, and also pregnancy, because of course, pregnancy, like birth control pill, causes an increase in CBG. Now, only after you have diagnosed Cushing syndrome, then you can go to the next step and try to figure out why the patient has hypercortisolism. And also, of course, the next step is to measure ACTH. And if the ACTH is low, then you have ACTH-independent Cushing syndrome, and then you, of course, image the adrenal by CT or MRI. If the ACTH is not suppressed, so is normal or high, then you are in the presence of an ACTH-dependent Cushing syndrome. In that case, ordering an MRI is, of course, appropriate. If there is an obvious adenoma, then I think that you can send the patient to surgeon. If there is no adenoma, or if there is equivocal, then you have the possibility of performing IPSS, inferior petrosal sinus sampling, if available in your institution by a competent neuroradiologist. If you don't have IPSS, then you can try to use other indirect ways to diagnose whether the patient has ectopic or pituitary Cushing. And one test that you can use is the CRH. CRH is no longer available in the US. I don't know if it is available in the Gulf, or a desmopressin stimulation test. The idea is that in general, pituitary Cushing responds cortisol and CTH respond to CRH or desmopressin, while they don't in ectopic, and of course associated with the whole body CT in the search of an ectopic source of a CTH. In my practice, if I have a young woman who has a CTH-dependent Cushing, I know already that the pretest probability of this being pituitary is very high. So if I see an adenoma that is not necessarily even below 6 millimeter, if it is 3 or 4 or 5 millimeter, if the adenoma is obvious by MRI, I usually refer the patient to our neurosurgeon. Okay. Second question is a 67-year-old man who was diagnosed with lung adenocarcinoma and was placed on immunotherapy with pembrolizumab, which is a PD-1 antibody, about 9 months prior presentation. His oncologist has been monitoring his thyroid blood test because she knows that patients on pembrolizumab are likely to develop thyroiditis, and has diagnosed him with primary hypothyroidism about 4 months ago. He's currently on levothyroxine 125 microgram a day. He now presents to the emergency room with nausea, dizziness, and lack of appetite. He is hypotensive and tachycardic, and he had an M cortisol, frankly low, 0.5 microgram per deciliter, with an unmeasurable ACTH. So the oncology team has diagnosed him with adrenal insufficiency and started him on hydrocortisone, and his symptoms have improved. By the time he makes it to your clinic, his blood pressure is normal, he looks better, and he denies polyuria and polydipsia. He has a normal testicular size. His free T4 and TSH and his serum testosterone are normal while on levothyroxine. You order a pituitary MRI. Which of the following is the most likely finding of the MRI? An empty cella, a normally appearing pituitary gland, a diffuse enlargement of the pituitary gland, or a large cellular mass consistent with pituitary metastasis? Okay, so this is very interesting. I'm happy when there is spread, because it means that there is some learning to be done. So about 40-40 normal appearing pituitary gland or diffuse pituitary enlargement, a few people thought that this could be a pituitary metastasis, and some people thought that this could be an empty cella. The answer is normal appearance pituitary, and we will go over why. So as you know, immune checkpoint inhibitors are now widely used in oncology. There are several classes, but the three main classes that are approved are antibodies against CTLA-4, PD-1, and PD-1 ligand. Most typically, the hypophysitis has been described initially in patients who were taking CTLA-4 antibodies, particularly for melanoma. And these patients can develop hypophysitis in up to 15% of the cases. Typically, in these patients, hypophysitis occurs quite early. The peak is about 8 to 9 weeks after starting therapy, and is often associated with headaches and mild to moderate pituitary enlargement. This looks more like the typical lymphocytic hypophysitis that you may see in a postpartum patient. However, PD-1 and PD-1 ligand antibody are much more likely to cause hypothyroidism than hypophysitis. However, when they affect the pituitary, this typically occurs later, about 7 to 9 months after starting therapy, but it's been described as later than 2 years. And for reasons that we don't fully understand, is most often manifesting as isolated CTH deficiency with a normal appearing pituitary gland. So in these patients, you would expect a normal appearing pituitary gland, to the point that sometimes in these cases, we don't even imagine their pituitary. Now, why don't I think that this is a pituitary metastasis? Of course, pituitary metastases are always possible in patients who have a metastatic cancer. However, it would be very unlikely for a metastasis to destroy the pituitary gland, causing central adrenal insufficiency, but not causing hypogonadism. And remember, I told you that these patients' testosterone was normal. In addition, the patient doesn't have polyuria and polydipsia, and typically, not always, but typically patients with pituitary metastasis present with diabetes insipidus. So I think that the most likely diagnosis here is isolated CTH deficiency due to the immune checkpoint inhibitor with normal pituitary MRI. By the way, you may have learned that there is now a tendency not to call diabetes insipidus anymore for fear of confounding the healthcare provider with diabetes mellitus. And the proposal is now to call it AVP deficiency, or AVP resistant in case of nephrogenic DI. To be honest, I still use diabetes insipidus. Very good. This is the third question. This is a 48-year-old gentleman who was diagnosed with hypogonadism by his primary care physician when he presented with several months of erectile dysfunction and headaches. Serum testosterone was 202 nanograms per deciliter with normal value in this assay between 300 and 900, with inappropriate normal LH and FSH. Prolactin was moderately elevated 89 nanograms per ml, which is about 1886 microunits per ml. His only medication is fluoxetine 20 milligrams a day. On physical exam, he has a normal blood pressure, mildly increased BMI. He has reduced peripheral vision on the right eye, and his testes are small. And MRI showed this very large cellular mass, as you can see here, with supracellular extension and chiasmatic compression, and some irregular heterogeneity, some heterogeneity seen particularly in the sagittal view. Which following will be most appropriate next step? Measure prolactin after dilution, start dopaminergic therapy, refer to neurosurgery. Again, let's not put until I've done reading the questions, because otherwise thanks. Refer to neurosurgery or repeat prolactin measurement after stopping fluoxetine. Okay. Great, there is a spread here too. So about 50% of people propose to repeat prolactin after dilution. The second question was refer to neurosurgery, and then a few other people wrote dopaminergic therapy or repeat prolactin after stopping fluoxetine. So fluoxetine and SSRI are only able to increase prolactin very mildly. But here the right answer is refer to neurosurgery. Why am I referring this patient to neurosurgery? In prolactinomas, there is a relationship between tumor size and prolactin level. So as most of you have understood, if this was a prolactinoma, you would have a much higher level of prolactin. But why I don't think that repeating prolactin after dilution is appropriate here? The hook effect occurs when concentration of the analyte, in this case prolactin, is so high that overwhelms the ability of the assay to create a sandwich, and I'll have a slide to show you this. This is very rare in modern assays and typically occurs with giant adenomas above 4 centimeters. Additionally, if this was a prolactinoma with a prolactin that was in several thousand, you would expect a much higher degree of hypogonadism than the mild degree of hypogonadism this patient has. And if this was a prolactinoma, let's say prolactin was 5,000 nanograms per ml, then dopaminergic therapy would have been reasonable given the, even in the presence of chiasmatic compression, as sometimes shrinkage can occur very fast. And as I mentioned, SSRI may cause a mild increase in prolactin, but not to this degree. Additionally, even lower or even normal prolactin of SSRI will not change surgical indication. So this patient needs surgery because of chiasmatic compression. This is a schematic representation of what happens when you have hook effect. Again, in 25 years of pituitary career, I've only seen one case of hook effect. There was a giant adenoma with about 7 centimeters in maximal diameter. So what happens when there is a hook effect? This is a standard. On the left, you can see the standard assay. There is a capturing antibody that binds to, in this case, prolactin. And then there is a detecting antibody, which is labeled with a fluorescent or with whatever radioimmunological material. And the assay depends on the creation of a sandwich between the two antibodies. When there is a vast excess of antigen, some amount of antigen binds to the capturing antibody, some amount of antigen binds to the detecting antibody, but there isn't enough of antibodies to create what we call a sandwich, and therefore the prolactin concentration reads inappropriately low. So in my practice, I only request dilution of prolactin where the tumors are very large, above 4 centimeters. We're doing with time. Okay. The fourth question is a 44-year-old woman who was noted by a physician family member during a family reunion that she hadn't seen for many years, that she looked different. And so she was recommended to discuss the possibility of having acromegaly. She has a history of hypertension for about 3 years on losartan, and she's also on birth control pill. On physical exam, she's mildly hypertensive. She has a BMI of 27. She does have a broad nose, no obvious prognatism, and some skin tags on her neck. She does report that the shoe size had increased from 38 to 38.5 over the past few years, but she thought that this was due to just gaining some weight. A random growth hormone is 1.2 nanogram per ml, and a serum IGF-1 is 298 nanogram per ml with normal value in this assay between 52 and 328. Just as a reminder to everybody, IGF-1 is a little bit of a tricky assay. You really need to learn how your assay performs, and also your assay should have age differential in terms of normal, because of course as we age, our IGF-1 goes down. So this has to be age adjusted normal. So her IGF-1 is within normal, though in the upper limit of normal. Which of the following would be the proper next step? Order a glucose suppression test, order a pituitary MRI, repeat an IGF-1 after stopping losartan, or there is no need for additional tests because she has a normal growth hormone and IGF-1. Great. So most people recommend ordering a glucose suppression test, and we'll talk why this should be done even in the face of a normal IGF-1. 6% of people order a pituitary MRI. Again, the theme here is that for when you suspect a secretory syndrome, don't order an MRI unless you have done a biochemical workup. Okay, this is the right question, the right answer. So the diagnosis of acromegaly is sometimes obvious. You can sometimes recognize people in the subway or the train station at the airport, and I'm always wondering, should I tell them or should I not? Because if I tell them and they already know they have acromegaly, they may feel offended. So it's always a struggle for every endocrinologist working in a crowded place. Professor Faglia in Milan many years ago used to send the endocrine fellows at the Milan train station to look for acromegalic patients. So they would stop people who looked acromegalic and invite them to their clinic. A frankly elevated serum IGF-1, of course, established the diagnosis with very low risk of false positivity. There is very few things can increase IGF-1 other than acromegaly, acute liver failure. However, serum growth hormone is often within normal limits. It's just that acromegaly patients never go to unmeasurable growth hormone level, while we have unmeasured growth hormone level for many hours during the day. However, milder form of acromegaly may not present obvious physical feature, and serum IGF-1 may be sometimes just borderline elevated or even normal. But particularly in a woman on oral estrogen, serum IGF-1 is reduced due to the first pass effect of the estrogen to the liver, which causes a resistance of the liver to the effect of growth hormone. And because more than 90% of the IGF-1 that circulates in the blood comes from the liver, if a woman is on an oral estrogen, her IGF-1 will be lower. And in fact, some endocrinologists use oral estrogen to treat mild acromegaly. So in cases like this, demonstrational lack of suppression by oral glucose established the diagnosis. Very important, contrary with what the last, now old Endocrine Society guidelines say, normally serum growth hormone should decline below 0.4 nanogram per ml. You must do a full test with measurement of 30, 60, 90, and 120. And again, as I mentioned to you for Cushing, given the high prevalence of small pituitary incidentalomas, ordering a pituitary MRI before a biochemical diagnosis is not appropriate. And losartan and other ARB don't have any effect on IGF-1 level, so repeating after stopping losartan was not the right answer. Great. So we shift gear now. This is a 32-year-old woman who presented with a history of irregular periods and excessive hair growth. She has had 2 children without fertility treatment. The last one was 4 years ago. On exam, she's overweight with normal blood pressure. She has mild acanthosis nigricans on the back of her neck. She has a terminal hair in her chin and chest. Her GYN doctor has already obtained some laboratory evaluation. She has a mild elevated prolactin, 48 nanogram per ml, about 1,000 microunits per ml. She has a normal TSH. She is not pregnant. And repeated prolactin is confirmed to be very similar at 50.4 nanogram per ml. So she has a mild or moderate, whatever you want to call it, prolactin. Which of the following will be the next appropriate step? Start dopaminergic therapy, order a macroprolactin test, order a pituitary MRI, measure serum IGF-1. Okay, so almost half of you guys would order a macroprolactin, 27% order a pituitary MRI, 13% measure IGF-1, and 14% just go straight to dopaminergic therapy. Okay. And the answer is order a macroprolactin test. And we'll talk why I think measured serum IGF-1, it would be reasonable if this is confirmed to be hyperprolactinemia. We'll talk about it. So the first point is that mild hyperprolactinemia is often transient. And therefore, whenever you have a mild hyperprolactinemia, you should always repeat. And I get a lot of referrals from the GYN department where without any very good reason, somebody has ordered a prolactin level that came back mild elevated, and they immediately sent the patient for an MRI, and the radiologist thought, well, maybe there is an adenoma because read that the patient has hyperprolactinemia. So in about 25% of the cases, if you have a mild increase in prolactin, it's normal when you repeat it. So the first thing is to repeat it. And this woman was repeated and was confirmed to be elevated. But in up to 40% in some studies of mild to moderate hyperprolactinemia, usually below 100 nanogram per ml, are caused by macroprolactin. And it's a condition that requires no treatment. So this woman likely has PCOS, which could be either the cause of her hirsutism, could be the cause of her hirsutism and their menstrual irregularities. And I agree that some adenoma can secrete both prolactin and growth hormone, and therefore measurement of IGF-1 is reasonable in a prolactinoma patient. But in this patient, the diagnosis of prolactinoma has not been established yet. We haven't ruled out macroprolactinemia. And again, I'm repeating it for the third time, given the high prevalence of pituitary incidentaloма, ordering an MRI before biochemical diagnosis is not appropriate, okay? And so this is a very important paper, which I think didn't get enough attention. It was published in Pituitary in 2015, where they took a bunch of patients who had elevated prolactin, and then they brought them back to the clinic. They put an angiocath, and they remeasured prolactin after 2 hours of resting with an angiocath in their arm, okay? And overall, in 27% of patients, they found the prolactin was normal, either because it was normal at the baseline when it was repeated, or in a 41 patient, or in a 23 patient because it normalized with rest. So the level of prolactin, the average level of prolactin in patients who have real hyperprolactinemia was higher than in patients who had who were found not to have confirmed hyperprolactinemia. The level was 77.2 in average. In the patients who were not confirmed to have hyperprolactinemia was 52.9. So the take-home message here is that mild to moderate hyperprolactinemia is often transient, and you should at least repeat it. And if you can, if you have access to a test where the patient can rest with an angiocath in his or her arm and repeat the prolactin after 2 hours, there is a subset of patients where you'll find that prolactin normalizes. Prolactin is a stress hormone, so some people get very stressed by the venipuncture. And this is what you see in a macroprolactinemia. As you know, prolactin monomeric is 23 kilodalton weight, but sometimes prolactin binds to immunoglobulin. And while the half-life of prolactin is about 1 hour, the half-life of prolactin bound to immunoglobulin is as long as the immunoglobulin's half-life, which is weeks. So prolactin in those cases accumulates in the serum, but has no biological activity. So in some centers, macroprolactin is checked in every hyperprolactinemia patient. In every patient, in some laboratory, every patient who has an abnormal prolactin, the laboratory reruns with macroprolactin assay. That is not done in our center, but I know there are centers that do it. And what the laboratory does, they measure the prolactin in the serum, then they add the polyethylene glycol, PEG, which precipitates immunoglobulin, and then they remeasure the prolactin in the supernatant. And what you will get a total prolactin, and then you will get a monomeric prolactin. So in this case, the patient's total prolactin was 50.4, which is about 2 times normal, but the free prolactin, the monomeric prolactin, was only 14. And so 71% of this patient prolactin was macroprolactinemia that has no biological consequences. So she doesn't need an MRI, she doesn't need to measure an IGF-1, she doesn't need dopaminergic therapy. The only thing she needs is informing her physician that her hyperprolactinemia is not real, and the only thing that needs to be done is never to check prolactin again. Okay, so then question number 6 is a 34-year-old female with history of Cushing disease who has undergone transsphenoidal surgery. Pathology confirmed the diagnosis of a CTH staining adenoma. However, there was some tumor in the left cavernous sinus, and therefore the surgeon could not fully cure it. So she has undergone gamma knife radiation to the residual adenoma 4 years ago, but her 24-hour urine-free cortisol remains elevated. She has persistent Cushing despite surgery and radiation. Her pituitary function is normal, her periods are regular, and she would like to conceive. The MRI shows below, as you can see, I put an arrow. There is a residual disease in the left cavernous sinus that even a very skilled neurosurgeon could not remove. Which of the following will be the proper next step? Start osilodrostat, bilateral adrenalectomy, start pasireotide, start ketoconazole or levoketoconazole. Okay, so this is a big spread, as probably there should be, because this is a tough situation. It's a very tough situation because the woman is not controlled. It's been 4 years from radiation, so the chance of radiation exerting its effect is close to zero at this point. The surgeon cannot cure her, so what are you going to do? And I think here, and that's my bias, the right answer is bilateral adrenalectomy. And the reason is that she wants to become pregnant. And none of these medications is approved during pregnancy. And unfortunately, having hypercortisone during pregnancy is dangerous, increase the risk of hypertension, diabetes, premature labor, stillbirth. So I think that the best option in this case is to remove the adrenal gland, as radical as it may sound. So persistent Cushing disease is a challenging scenario. When possible, reduced surgery should be considered, but in this case, this was not an option. Radiation therapy is very efficient in preventing tumor growth, but is less efficient in normalizing cortisol level, and the outcome, the positive outcome is seen in about 60 to 80% of the cases. Most of the effects of radiation are seen in the initial 2 years. After 4 years, as we mentioned, she is unlikely to get additional effect from radiation. Several drugs are now available to treat Cushing disease, but none is safe in pregnancy. And so bilateral adrenalectomy, I think it's an underused treatment of persistent Cushing. And, you know, you would worry about Nelson syndrome, of course, but the risk of Nelson syndrome is dramatically reduced in patients with significant, with prior radiation. So this is a slide that shows you the current available medication to treat Cushing disease. The pituitary-directed drugs, as you can see, is pasireotide that can be given as a subcutaneous or as a monthly intramuscular injection. It's approved, at least in the US, to treat Cushing disease. Cabergoline can be used off-label to treat Cushing disease. In my experience, is very few patients respond, and often they escape from response. You can try it in a patient with mild Cushing disease. Then, of course, there are adrenally directed drugs. Osilodrostat, which blocks the last enzyme in the synthesis of cortisol, 11-beta-hydroxylase, is approved, at least in the US, to treat Cushing disease. Levoketoconazole, which is the L form of the racemic ketoconazole, is now approved in the US to treat Cushing disease. Is very similar to ketoconazole. It's supposed to have less liver toxicity and more specificity, but in fact, there has never been a study that compared ketoconazole with levoketoconazole. I know the ketoconazole is approved in Europe to treat Cushing disease. I don't know if it is approved in the Gulf region. Ketoconazole in the US is only approved to treat fungal infection. We have been using it off-label to treat Cushing before levoketoconazole was approved. Of course, metyrapone is approved in Europe. It's not approved in the US other than for testing. Mitoten is typically used only for adrenal cancer, and etomidate, you can use it IV in cases of very severe Cushing as a last ratio. And then, of course, the glucocorticoid receptor blocker, the only one available in the US is mifepristone. This has the complication that you cannot it's not specific for glucocorticoreceptor, also acts on the progesterone receptor, causing endometrial hyperplasia, of course, in women. And of course, you cannot measure anything because cortisol, if anything, goes up. So you have to treat the patient just based on clinical features. There is a newer form of glucocorticoreceptor blocker called relacorilant, which is under investigation now, which is supposed to be specific for the glucocorticoreceptor. And hopefully this will be available in the next few years. Question number 7. This is a 47-year-old gentleman who is referred from the neurology clinic to rule out endocrine abnormalities. He complains of feeling unwell after he had a severe traumatic brain injury that occurred about 2 years ago during a motor vehicle accident. He is currently on sertraline 100 milligram a day and carbamazepine 200 milligram twice a day for seizure that started occurring after that traumatic brain injury. On exam, his blood pressure is normal, he has a BMI of 28, and the tests are normal size. The lab evaluation showed cortisol in the morning of 16.1 microgram per deciliter, 441 nanomole per liter, the normal free T4, normal TSH, normal testosterone, and IGF-1, which is 123 nanogram per ml, with normal value in this age group in this assay between 81 and 263. Which of the following will be the appropriate next step? Hypopituitarism was ruled out, so there is nothing else to be done. Repeat free T4 and IGF-1 after stopping carbamazepine. Measure T3, order a growth hormone stimulation test. Great. So the majority of you guys propose to order a growth hormone stimulation test. And in fact, this is the correct answer. Okay, so as you know, traumatic brain injury is a common cause of hypopituitarism, with a prevalence after a large TBI can be as high as 25%. The most frequent endocrine feature is isolated growth hormone deficiency. And in this patient, we know that his AM cortisol is normal, his free T4 is normal, his testosterone is normal. So we know that those other axes are normal, but he may have isolated growth hormone deficiency. And the important point is that a normal IGF-1 does not rule out growth hormone deficiency, particularly in males. Many males have normal IGF-1 despite growth hormone deficiency. Now, carbamazepine, Tegretol, can reduce free T4 level, but it does not affect serum IGF-1 level. And generally, measure of T3 is not useful in diagnosis central hypothyroidism. So several growth hormone stimulation tests are available. And the very important thing that you have to keep in mind that many of them are heavily influenced by BMI. Therefore, the cutoff must be individualized. Massimorelli, I don't know, I would like to know whether it's available to you in the Gulf. Massimorelli is a great test. Massimorelli is a ghrelin agonist that acts on the ghrelin receptor. Doesn't seem from the current literature to be influenced by BMI, at least up to a BMI of 37. So Massimorelli is, and it's very easy, short, and quite pleasant in terms of no significant side effect. This is an old study published now 25 years ago that showed how IGF-1 is not a test to diagnose growth hormone deficiency. This is a group of female on the left and males on the right. This is their IGF-1, and yellow is the normal IGF-1. This is the mean plus or minus 2 standard deviation. And as you can see, particularly in males, many males who were proven to be growth hormone deficiency, here they use ITT as the gold standard, insulin tolerance test. So these were really growth hormone deficient. And you can see many patients had normal IGF-1. In fact, some patients had IGF-1 in the upper range of normal, and still they had growth hormone deficiency. So IGF-1 is not a good test. If it is low, certainly suggests growth hormone deficiency, but if it is normal, it doesn't rule it out, particularly in males. So which tests are available to diagnose growth hormone deficiency? Insulin tolerance test, GH-raised plus arginine, glucagon, as I mentioned, Massimorelli. Okay, so how about in terms of accuracy? ITT is very accurate, GH-raised plus arginine is very accurate, Massimorelli accurate. Glucagon, it depends on BMI. If the patient is lean, it's accurate. If the patient is overweight, it's more difficult to interpret. Is it safe? Of course, ITT is not always safe. The others are pretty safe. ITT is not simple. You have to have a close medical supervision. GH-raised plus arginine is simple, Massimorelli is simple. Glucagon, I wrote why not, yes, not, because it's very long and can have and in fact, It's not a speedy test. You have to, if you use glucagon, you have to go to 4 hours because about 6% of patients will peak in the 4th hour. So if you cut it at 3 hours, you'll miss 6% of the peaks. Is it available? ITT, of course, is always available. Everybody's got insulin. GHRH plus arginine has not been available in the US for the past 15 years because of GHRH is not available to us. Glucagon, of course, is available. Massimorelin is available in the US, but as you can see here, it's very expensive in the US. I'd love to hear during the discussion if you guys use it and how expensive it is. Glucagon is not expensive. GHRH plus arginine depends on the cost of GHRH in your region. And of course, ITT is not expensive. How about the cutoff that you use? Okay, this is the cutoff recommended by the Growth Hormone Research Society in 2007, ACE in 2009, Endocrine Society 2011, and ACE again in 2019. I think we can look at the ACE recommendation in 2018. As you can see here, the ITT is below 5.0 nanogram per ml. ACE doesn't recommend a cutoff for GHRH plus arginine because in America we don't have GHRH, so you have to look here. And this depends on your BMI. BMI below 25, the cutoff is 11. BMI between 25 and 30, cutoff is 8. BMI above 30, cutoff is 4. For glucagon, it gets a little more complicated. If your BMI is below 25, your peak should be above 3. If your BMI is above 30, should be above 1. If your BMI is between 25 and 30, which most patients fall in, then there is a debate on whether normal should be 3 or 1. And I don't think the debate is still resolved. In Massimorelin, it's very interesting because the studies that led to the approval of Massimorelin analyzed the data and showed that the appropriate cutoff was 5.1 nanogram per ml. But the FDA, the American Food and Drug Administration, I guess to reduce the chance of false positive, placed the cutoff at 2.8. So if you are below 2.8, you have growth hormone deficiency. If you are above 5.1, you don't have it. Between 2.8 and 5.1, in my book, Reading the Dictionary, is still growth hormone deficiency. For the FDA is not, and unfortunately for insurance in America is not. And arginine by itself, of course, is not recommended as a poor test. Now, does everybody who has hypopituitarism needs a growth hormone stimulation test? The answer is no. This is an old study, is now more than 20 years old, but it's still valid. This graph looks at the number of, the chance of patients to be growth hormone deficient based on whether or not they have additional pituitary hormone deficit. So these are all patients with some history of pituitary disease. And you can see here, if you have otherwise normal pituitary function, but you have, let's say, a pituitary tumor, you have about 41% chance of being growth hormone deficient. Let's say you have central hypogonadism. Your chance goes to 67%. Let's say you also have central hypothyroidism. Your chance gets to 83%. Let's say you also have adrenal insufficiency. Your chance gets to 96%. You also have diabetes insipidus. Then you're 99% sure to have growth hormone deficiency. So in patients who have a pan-hypopituitarism, mean 3 or 4 pituitary hormone deficiency, you don't need a growth hormone stimulation test. You can make a case that their chance of being growth hormone deficient is so high that the growth hormone stimulation test is not needed. And by the way, I use this slide when I write appeal letters for insurance companies where they deny growth hormone based on the lack of growth hormone stimulation test. And I write, look, this patient has a 99% chance of being growth hormone deficient. If you want to pay for a growth hormone stimulation test, of course we can do it, but I think it's redundant. And most of the time, actually, the insurance agrees with that. Okay, next case. This is a 50-year-old man with history of acromegaly due to a large macroadenoma, has already undergone the bulking surgery of this tumor, as you can see here on the left, very large tumor with supracellular extension, and had some improvement of growth hormone IGF-1, but of course without cure. Pathology reports a sparsely granulated tumor. 3 months after surgery, a random growth hormone is 2.3, and the IGF-1 is still elevated at 523 nanogram per ml with normal value up to 298. On exam, he looks pretty good, and he has a normal pituitary function. Hemoglobin A1C is 5.3%. And this is on the left, the MRI prior to is the bulking surgery. This after the bulking surgery. As expected, there is a residual tumor on the side, on the right side. Which of the following will be the appropriate next step? Start octreotide, start pegvisomant, start pastireotide, or refer for radiation therapy. Okay, so there is a very large spread here. 45% of you recommend starting octreotide, 13% pegvisomant, 27% pasireotide, and 15% radiation therapy. And to be honest, the goal of this question is to discuss and to raise issues. In my mind, in this patient, the right answer is pasireotide, and I'll explain you why. So, as you know, growth hormone-secreted adenoma come in different types, but mostly they are divided in densely and sparsely granulated adenoma. Sparsely granulated adenomas are really, in general, much larger, are more frequent invasive, and in general, they are less efficient in secreting growth hormone. And in fact, they often present with mass effect without obvious acromegaly features. In the T2-weighted MRI images, they tend to be hyperdense. So these sparsely granulated tumors are much less likely to respond to first-generation somatostatin receptor ligands, such as loctitide and lariotide. And they're more likely to express somatostatin receptor type 5 and respond to pasireotide. Of course, the main side effect is worsening glucose control. As you know, pasireotide worsens glucose control in about 75% of the cases. Now, radiation therapy is effective in preventing tumor growth, but in particular in acromegaly, it may take many, many years to normalize growth hormone secretion. So even if you decide to radiate this patient, you wouldn't expect radiation to normalize growth hormone until many years later. And because pegvisomant has no effect on tumor growth, you would likely normalize this patient IGF-1, but you would really worry about residual tumor growth, and therefore I don't think pegvisomant would be the right answer here. And so this is the result of the study that led to the approval of pasireotide in acromegaly. Was published in 2014 in the JCNM. And as you can see here, first of all, these were all patients who were completely naive to any kind of medical therapy. And they were either completely naive to any therapy or were people who had failed surgery. And as you can see here, the percentage of patients that had a growth hormone below 2.5 and a normal IGF-1 was higher overall with pasireotide in black compared to octreotide LAR in gray. And this was true both for post-surgical patients and patients who had not been operated. And I think the biggest, there are two important points that this study showed. One is that overall pasireotide was more effective than octreotide LAR to normalize growth hormone IGF-1. But actually, the other important take-home message in this study is that the percentage of patients who responded to somatostatin analogs in general was much lower than most of the previous studies had shown. And I think this is due to the fact that these patients were all naive, they were not selected, and many of them had a very severe degree of acromegaly. And in this study, as you can see here, this is the percent reduction of IGF-1 from month 0 to month 6, and this is the percent reduction of growth hormone. And as you can see here, when you treat the patient with somatostatin receptor ligand, if they are densely granulated, they have a higher likelihood to respond than sparsely granulated, both in terms of IGF-1 than in terms of growth hormone level. So if your pathologist is able to give you a result and tells you the patient has a sparsely granulated adenoma, I think that you can predict that this patient is very unlikely to respond to first-generation somatostatin receptor ligand, and you should consider pasireotide. This is a algorithm, and I'll leave it here. I won't go into detail because it was going to take too much time. But as you can of the treatment of acromegaly, but as you can see, there are a lot of arrows going in many directions. And just to show how complicated sometimes and how sometimes physician-dependent the treatment of acromegaly is. I think in my center, very few patients do not get surgery. Surgery, of course, is indicated in patients who have microadenoma or intracellular macro in the hope of curing them. But sometimes surgery indicated in patients with large tumors to reduce mass effect, and also sometimes to increase the chance of somatostatin receptor ligand to work, because there is a study from Italy that shows that patients who were the bulk are more likely to normalize their IGF-1 by medication. But if a patient is not controlled, there is a whole bunch of possibility. You can use, you can switch therapy, you can use combination therapy. This will be sort of the topic of a whole completely different lecture. And you can refer to this paper that was the result of one of the acromegaly consensus conference that we hold on a regular basis, led by Dr. Justina and Dr. Melmed. Okay. Question number 9. If we make time. A 22-year-old woman presents with vision changes and large cellular mass. Her laboratory evaluation shows an elevated serum IGF-1, 652, and a moderate elevated prolactin. Mother and father, age 52, have hypertension but no other disease. The mother, however, has a history of kidney stones, but reports a recent normal calcium. A maternal uncle may have had a pituitary adenoma, but they are not sure about that. However, the older sister was operated for a non-functioning macroadenoma at age 23. So she's 22, she has elevated IGF-1, elevated prolactin, and a sister with a non-functioning pituitary adenoma also in young age. Her exam shows a normal blood pressure and a mild elevated BMI. This is her MRI. It shows a very large adenoma with supracellular extension, chiasmatic compression. This is the coronal view and the sagittal view. Which of the following genes is more likely to be mutated in this patient? Menin gene, AIP gene, PRKRA1 gene, or cyclin B? Great. So there is some spread, but most of you mention AIP, which is aryl hydrocarbon receptor interactive protein. That's the correct answer here, and I will go over why. Okay. As you know, most of pituitary adenoma are sporadic, but they can be seen in familial disease in up to 5% of the cases. In general, when patients present with familial disease, they're more likely to have a large tumor occurring at a young age, and this woman was in her early 20s with a very large growth hormone-secreting adenoma. The most frequent gene mutation that causes predisposition to pituitary adenoma is the AIP gene mutation. However, the penetrance of this mutation is low, and this is due to the Knudsen hypothesis. You inherit 2 alleles from your parents, and generally 2 alleles are normal. A patient with AIP mutation has 1 faulty allele, but in order for the patient to have adenoma, because this is a tumor suppressor gene, they must lose the function of the other allele, and this happens randomly. So not everybody with the AIP mutation develops an adenoma, only about 15 to 30%. And therefore, pituitary adenoma phenotype can skip several generations. Typically, patients with AIP mutation presents with very early onset large macroadenoma with a high percentage of them secreting growth hormone. And in fact, AIP mutation are rather prevalent in patients who are giants, who have growth hormone secreting adenomas that occur in a young age. Now, as some of you wrote, MEN1 gene mutation, menin gene mutation can include pituitary adenoma. But pretty much 99% of patients with MEN1 syndrome have hypercalcemia by age 50. Her mother is above age 50 and doesn't have hypercalcemia. So that's why I think MEN syndrome in this case was very unlikely. In fact, this patient did have an AIP mutation. Now, PRKRA1 mutation can cause Carney complex, which can be associated with acromegaly, but this is more rare and is associated with other features like cardiac myxoma, post-tubal adrenal Cushing, hyperpigmentation in the lips, pituitary thyroid adenomas, testicular tumors, and this patient didn't have any of these features. And cyclin B germline mutation have not been reported in pituitary adenoma. So the right answer is AIP mutation in this case, and that's what actually she had. Question 10. This is a 73-year-old woman who presented to the emergency room with an episode of syncope due to hypotension. She was diagnosed with central adrenal insufficient central hypothyroidism. Prolactin was mildly elevated, 32 nanogram per ml, and this was confirmed after dilution. After treatment with hydrocortisone and levothyroxine, she developed polyuria and polydipsia. After 14 hours of food withdrawal, she had a sodium of 145, a serum osmolarity of 301, and a urine osmolarity of 475. Chest CT is normal. Which of the following is the most important next step? Start cabergoline, obtain a pituitary biopsy, measure macroprolactin, or refer to neuro-ophthalmology. Okay. So referred to neuroophthalmology was in most people, measure macroprolactin few, biopsy 20%, and Zuckerberg 10%. So this is a tough case, but I think that's what I did in this case. I ordered a pituitary biopsy, and I'll tell you why. So let me go back 1 second to this. And you can see this is a very large mass, extends below and above. It's very irregular in shape. It's got sort of a snowman kind of appearance. And it does compress the optic chiasm. But I think that here the diagnosis is, to make the diagnosis is extremely important. And the patient has evidence of diabetes insipidus, okay? The urine osmolarity should be at least 600 milliosmol, 2 times the serum osmolarity. So diabetes insipidus is very, very rare in pituitary adenomas that are not operated, no matter how large they are. So I knew that this was not a pituitary adenoma. And so this must be some other pathology. And as we mentioned in a previous case, pituitary metastasis can frequently cause diabetes insipidus. The most common causes are breast cancer, lung, and melanoma. And therefore, the biopsy is needed. And these turn out to be a small cell lung cancer, which actually a chest X-ray, the chest CT had missed. And the neuroophthalmological exam will likely be abnormal, but I don't think it would change the indication for a biopsy. This patient needs a diagnosis as soon as possible, and she did, and she's now undergoing chemotherapy for her small cell lung cancer. Question 11. This is a 33-year-old woman who underwent an MRI of the brain for new onset headaches. The MRI showed a 4 millimeter hypoenhancing lesion in the far lateral aspect of the left pituitary gland, likely representing a pituitary adenoma. She has normal periods. She has a normal exam, a normal BMI, and the lab work shows normal prolactin and normal IGF-1. And here you can see, I put the green arrow. This is the adenoma on the left. The most appropriate next step is obtain a dexamethasone suppression test, measure a free T4, repeat an MRI in 3 years, or measure serum cortisol in the morning. Wow, there is a big, big spread. Okay, so I think the right question here, the right answer here is repeat an MRI in 3 years. Why? As you know, incidentally found pituitary microadenomas are very common in the general population, up to 10%. It is recommended that all patients with a microadenoma have a measurement of prolactin and IGF-1. So this patient had a normal prolactin, normal IGF-1. But the screening for Cushing is recommended only in the appropriate clinical scenario. This woman had normal BMI and normal blood pressure, so she had absolutely no feature of Cushing disease. And microadenomas, particularly if below 5 millimeters like this one, are very rarely the cause of hypopituitarism. Therefore, I don't think this patient needs hypopituitary screening. And in fact, she had normal periods, which confirmed that pituitary is working fine. So recent literature shows that these small incidentalomas grow very rarely, and when they do, they grow very slowly. Therefore, an MRI in 3 years is the appropriate answer. And this is a paper that I encourage you to read. It was published very recently by a UK group in the European Journal of Endocrinology. And they looked at the natural history of 419 patients with a micro non-functioning adenoma, median age 44. And the cumulative probability of growth was 7.8% at 3 years and 14.5% at 5 years. And actually it was was lower actually to the cumulative probability of reduction in size, which was 14% at 21.3% at 3-5 years. So these adenomas were more likely to shrink than to grow. And the median enlargement was 2 millimeters. Only 49% that grew became macros. Only 8, so 1.9% of patients needed surgery. And only 0.6% developed hypopituitarism during follow-up, okay? So as you can see here, most patients, the tumor remains stable in 70% of patients. In about 19% of patients, the tumor shrank, and only 12% of the patient tumor enlarged. And as you can see here in the Kaplan-Meier curve, most of the enlargement appeared in the first 10 years, and then there was nothing. And if you look at the division, this is, I think, the most interesting part, between microadenomas that were above or below 5 millimeters. If you look at the below 5 millimeters here, which is the case that we presented, the growth at after 2 years, after 1 year was 0%, after 2 years was 1.1%, after 3 years was 4.6%. So essentially, there is really no sense to do an MRI at 1 or 2 And even 3 years is probably overkilling because the ones that mostly grew at 5 or 7 years. But anyhow, their conclusion is that you can safely wait 3 years, particularly in patients who have microadenoma that are below 5 millimeter. If they are above equal or below 5 millimeter, if they're above 5 millimeter, there is a little bit of a higher risk, but still, again, only about 10% grew at 3 years. So this is a 39-year-old man who presents with visual field changes. Prolactin was exceedingly high, 22,934 nanogram per ml, which is 487,000 and change milliunits per ml. Testosterone was low at 126. He had a low free T4, normal TSH, and a morning course of the rule out adrenal insufficiency. He had a frankly abnormal visual field test even at the bedside. And this is a very large adenoma. This, of course, a macroprolactinoma with invasion of the both cavernous sinus, compression of the chiasma. This patient actually was diagnosed because he was getting married, and he confessed to his mother, who was a physician, that he had erectile dysfunction since college age, so for about 20 years, which he had never confessed to anybody. So the most appropriate step is to start cabergoline, refer to neurosurgery, refer to radiation oncology, repeat a prolactin after dilution. Okay, so the vast majority of you recommend the start cabergoline, some refer to neurosurgery. Okay, so the right answer is start cabergoline. So this patient has a giant macroprolactinoma causing vision changes and partial hypopituitaris, which is hypogonadism and hypothyroidism. Surgical cure cannot be reached due to bilateral cavernous sinus invasion. And so sometimes you can see rapid reduction in tumor size with dopaminergic therapy. And therefore, I think that surgery in this patient should be placed on hold. Radiation is the last resort in treating dopaminergic agent-resistant prolactinoma. And there is no need to repeat prolactin after dilution because the result is already frankly abnormal. Okay. So this is a paper that was published in the Endocrine Practice 2 years ago, looking at patients, 71 patients with giant prolactinoma. As you know, giant is a tumor above 4 centimeters. And in the majority of patients, 55%, achieve prolactin normalization in the long term. And 26% actually had no tumor visible at follow-up. So their conclusion is that most patients with the giant prolactinomas have excellent response to dopaminergic agent. Sex, age, initial prolactin did not predict therapeutic response. Just as in addition to this, remember, most of these giant prolactinomas occur in males. They're very unlikely to occur in females. Somebody thinks that this is due to the fact that women are alerted about hyperprolactinemia by loss of period earlier. But I think there is a really different biology here that for some reason males have these very large, more aggressive adenomas. And interesting enough, some of these patients can recover their pituitary function while you treat them with dopaminergic agents. This is a paper that looked at the pituitary function of 35 males with the macroprolactinomas. At diagnosis, 77% were hypogonadal, 41% at central hypothyroidism, 23% at adrenal insufficiency. And in 29% of patients, so which is 83, I'm sorry, 29 patients, which is 83%, prolactin level reached normal or near normal level, similar, even better than was seen at the Mayo Clinic study. But I think most important is that in 4 out of the 9 patients who had central hypothyroidism, and in central hypothyroidism recovered after treatment when the tumor shrunk, and so did adrenal insufficiency in 4 out of 6, and gonadal function in 16 out of 26. And there were 8 patients who had both central hypothyroidism and central adrenal insufficiency, and they recover at least one axis in 75% of the case. So this is very good because you can tell this patient, okay, you have central hypothyroidism, you have central hypoadrenalism, I'm going to start treating you. But then when the tumor shrinks with medication, I'm going to reassess your adrenal, your thyroid, your gonadal function because you may get, you may recover and not need this medication for lifetime. So this patient was treated, in fact, with cabergoline, and after about 1 year, his prolactin was nearly normal at 18.0 nanogram per ml. His visual field exam normalized. However, his testosterone remained low, 177, and his free T4 normalized. And you can see here, this is the initial MRI. After 1 year, the tumor is shrunken significantly. The chiasma is no longer compressed. There is some cystic degeneration in the tumor, which you like to see because it means that there are dead cells. However, you know, he was recently married, was complaining of erectile dysfunction. He was very stressed by this. So he was started on testosterone replacement therapy. in the form of testosterone gel. After 3 months, his testosterone normalized on therapy, but his prolactin went from 18 to 198. The most appropriate next step is increase the cabergoline dose. At this point, refer to neurosurgery, stop the testosterone, or start an aromatase inhibitor. Great. So this is there is a big spread here. I certainly will not stop testosterone. The poor guy is recently married. He has erectile dysfunction. I don't think neurosurgery is an issue because, you know, they still cannot cure him. So it either increasing cabergoline dose or start an aromatase inhibitor. And in my answer is start an aromatase inhibitor. And this has been described initially for the first time several years ago by Dr. Molich's group in 2002. This was a case of a patient with a large prolactinoma with a prolactin 600 nanogram per ml. He was treated with cabergoline, did well, and then he got testosterone. As you can see, prolactin increased. And why does prolactin increase when you add testosterone in some of these cases? Because testosterone is aromatized to estradiol, and estradiol, of course, is a growth factor for prolactinomas. And here he was added anastrozole, and his prolactin normalized. And that's what I did in this patient. I added anastrozole, and his prolactin normalized without the need for increased cabergoline or without the need of stopping testosterone. The next case is a 22-year-old man who presented with recent onset of severe polyuria and polydipsia with a total volume of 12 liters of urine 24 hours. The urine is diluted. He was diagnosed with AVP deficiency resistance by his internist and started desmopressing, and urination normalized. He had a normal morning cortisol, a normal free T4, and a testosterone which was below normal with normal, inappropriately normal H and FSH. He was proposed testosterone therapy, but he refused because he was afraid of a reduction in fertility. This is an MRI that shows a normal pituitary gland and a thickening of the pituitary stalk of about 4 to 5 millimeters, as you can see here in this sagittal view. So he was diagnosed already with diabetes insipidus. How do you diagnose diabetes insipidus? If you can get the serum osmolarity above 295 and the urine osmolarity is above 200, the diagnosis is established. Sometimes you need to do a water deprivation test. Rarely, to be honest, necessary a formal deprivation test. One blood test that can help you nowadays to diagnose diabetes insipidus measurement, copeptin. Copeptin is the C-terminus of the pro-ADH molecule. As you know, ADH, vasopressin, is very unstable. It's very difficult to measure. But copeptin, which is produced in equimolar manner to AVP, is actually much more stable and can be measured in the serum. So I don't know if this is available to you guys currently, but it's a very good test because it's a surrogate for ADH. And is if you look at the baseline copeptin, even without doing any water deprivation test, complete differentiates between nephrogenic diabetes insipidus and central diabetes insipidus. In nephrogenic diabetes insipidus, copeptin is always invariably above 21.4 picomole per liter. If it is below 21, then you can try to use copeptin to differentiate between complete or partial central DI and primary polydipsia. This is a long discussion we can have, how you stimulate, whether you stimulate with water deprivation, with infusion of hypertonic saline, or you can even use arginine. But this is, I encourage you to look into Dr. Chris papers from Switzerland, who has published extensively about the use of copeptin in this disease. So this patient has obviously diabetes insipidus. He has responded nicely to desmopressin. So you know this is central DI. He has thickening of the pituitary stalk. So what is the proper next step? Pituitary stalk biopsies, measurement of serum alpha-fetoprotein, skeletal survey, or lumbar puncture. Okay, so there is a big spread here. And my answer here is skeletal survey. And why do I say this? So this man has diabetes insipidus. Nobody can argue with that. He has central DI. The differential diagnosis in this case include Langerhans cell histiocytosis, sarcoidosis, germinoma, lymphoma, lymphocytic hypophysaris. In this case, would be infundibulitis. Of course, a biopsy will lead to diagnosis, but it's an invasive procedure. And of course, his pituitary function with exceptional hypogonadism is normal, so you may cause further damage to the pituitary function. Measure of alpha-fetoprotein and beta-HCG has a very low yield in diagnosis of germinoma teratoma, at least serum. CSF measurement is more likely. However, about 2/3 of patients with Langerhans cell histiocytosis have lytic bone lesions. And if present, you can biopsy them and get a pathological diagnosis. So I think that the easiest thing, the first thing to do is just a simple skeletal survey to look for these lesions. If they're present, you can biopsy and you have a diagnosis. If they're not, then you must progress with the differential diagnosis. A chest CT may be useful in search of sarcoidosis. I think we have time for one more question. Okay, so proceeding with this case, his skeletal survey, chest CT, and blood tests were all negative. He was responding well to desmopressing. So a decision was made to watch him repeat imaging in 3 months. MRI at 3 and 6 months were unchanged. And actually, in a follow-up appointment, he reported that his polyuria had improved and he no longer needed desmopressing. What is the more appropriate next step? Order an AM cortisol, reduce the frequency of MRIs, repeated chest CT, order a renal sonogram. Why is he no longer requiring desmopressing? Great. So 2/3 of you guys got it right. He has developed adrenal insufficiency. And diabetes insipidus never resolves when it's due to infiltrated inflammatory disease, may resolve after trauma. Something is now masking diabetes insipidus. Of course, it's possible that he has some urological problem, but he's a young man, so the chance of him having BPH is very unlikely. The most likely cause of reduced polyuria in this case is development of adrenal insufficiency. Glucocorticoids increase GFR and stimulate vasopressinase. Indeed, some patients with panhypopituitarism diabetes insipidus do not develop DI until you replace their glucocorticoid. And in fact, the patient had developed adrenal insufficiency, and we eventually biopsied the lesion and was a germinoma. So I think that I have 3 more questions, but I have to leave some time for questions. So I'll stop here. And I'll take any question that the moderator wants me to answer.
Thanks, thank you, Prof, for the excellent review. So we have some questions. We'll start with the first one. In regards to question 1, you mentioned regarding the false increase in cortisol level with the oral OCP. Someone asked about what about the transdermal estrogen? Do they have?
Yeah. That's a great question. Transdermal estrogen are not supposed to cause increase in cortisol binding globulin, and certainly this an issue also comes about when patients who have growth hormone deficiency, female patients who have growth hormone deficiency. If you treat them with oral estrogen, you cause a resistance of the liver to growth hormone, and transdermal estrogen doesn't do that. So in general, transdermal doesn't increase cortisol binding globulin.
Excellent. In regard to question number 5, question regarding the PCOS. After ruling macroprolactinemia assay related, if it is still persistent prolactin elevation, will you proceed with MRI with this mild hyperprolactinemia?
The answer is yes. And the reason is that although the vast majority of patients with mild to moderate confirmed hyperprolactinemia will have a microadenoma, you cannot be sure that this patient doesn't have a larger cellular mass causing hyperprolactinemia by compression of the stalk. So at least once you need to image their pituitary to rule out a larger mass.
Amazing. Another question in regard to, again, to the macroprolactin. So you showed us how the macroprolactin is estimated. The question is, the prolactin level post-pigulation, the reference range would be the same as pre-pigulation?
Yeah, so essentially what the laboratory is going to give you is going to give you a monomeric prolactin value, which is the real prolactin, the one that's free in the serum. And then you can interpret that based on the normal value in the particular laboratory. Just keep in mind that some patients may have a prolactinoma and a significant percentage of macroprolactin. I've seen them. So somebody may have a prolactin of 120, 150, and maybe 50% is macroprolactin, but their monomeric prolactin is still 75 nanogram per ml, which is abnormal. So the patient still has a hyperprolactinemia, just to a degree that is lower. I saw a patient recently with an adenoma that was 6 millimeter. Her prolactin was 300 nanogram per ml, which is very high. And it turns out that the real prolactin was 60. The most of the prolactin was macroprolactin, but she still had a prolactinoma. So you have to look at the normal value of monomeric prolactin in that lab.
So, another question about the cutoff or the expected stimulation of ACTH and cortisol with the peripheral DDAVP stimulation test for ACTH dependent Cushing. Will the cutoff be similar to CRH stimulation test?
That's a great question. And there is a beautiful paper published in the European Journal of Endocrinology by Dr. Stagarakis from Greece that has a table where he lists all the different cutoffs that have been used for the desmopressin test. And there are about 10 different cutoffs. So there is really no uniform interpretation. I usually look at least a 30% increase in cortisol and or ACTH. Sometimes there is a little bit of variability just based on normal variability, but I think that the more the higher the degree of increase of ACTH and cortisol you see, the more likely you are facing Cushing disease. But I would encourage you to look at the paper. The last name is Tsagarakis in the European Journal of Endocrinology. There is a big table, and you realize how non-uniform the interpretation of the desmopressin test is.
Excellent. Someone asked for your comment about the risk of CSF leak after starting cabergoline for giant prolactinoma.
That's a great question. This can happen if the tumor has grown downwards and has broken the floor of the cell, and the tumor is sort of creating a cork. And if you shrink the tumor with medication, you can cause a CSF leak. It's something that you should always warn the patient about when you start on cabergoline in this patient. You should tell them if they have a salty, clear fluid dripping in behind their throat and from their nose, they should immediately seek medical attention. To be honest, I only saw it once, although, and this happened rather rapidly. It was a giant prolactinoma. I saw a patient this week, actually, who has been on cabergoline for about 5 years, and the tumor has got significant shrinkage, and he is telling me, and he gave me a very good history of what it sounds like CSF leak, so this may be my second. I'd be surprised after 5 years of therapy. So it's rare, but can happen, and certainly something that you should warn your patient about.
The next question is about the OGTT result for acromegaly. So the question is whether the decline in growth hormone, they mentioned about initial decline and then it rises again. Seems like a paradoxical response. Will it rule out? What should they do next?
I think that the most important thing is that you look at the nadir growth hormone. What's the lowest growth hormone level that you reach? There is some literature that seem to show that people who have sort of a paradox response, in other words, they increase their growth hormone instead of decreasing, may be less likely to respond to somatostatin receptor ligand, but I don't think that's really confirmed. But you must look at the nadir level, no matter when that occurs. And I've seen patients evaluated by endocrinologists where they were told that they had acromegaly because at 120 minutes their growth hormone was not suppressed, but they missed they had not done 30, 60, 90. And so you really must do 30, 60, 90 and look at the lowest level. No matter what is the time point, if they reach a level below 0.4, acromegaly is ruled out. Excellent.
There was a question also if the patient is on oral estrogen and they want to check AM cortisol. I mean, do they still can interpret it in patients who are on oral estrogen?
Well, I think that depends on whether you're thinking about DEX suppression test or ruling out adrenal insufficiency. For the DEX suppression test, if a patient on oral estrogen suppresses below 1.8 microgram per deciliter, 50 nanomole per liter, then they don't have Cushing. But if they don't suppress, you have to repeat it after a month of being off estrogen. To rule out adrenal insufficiency, you have to consider that oral estrogen will artificially increase their total serum cortisol. Unfortunately, contrary to, let's say, calcium and albumin, there isn't a correction factor. So, the degree by which the oral estrogen will increase the total serum cortisol is very variable. So, but, you need to keep that in mind. So if you're calling the ICU and a patient is on oral estrogen and her cortisol level is 12 and maximally stressed, then you may think, well, this would be almost normal. But, this patient is on oral estrogen, the CBG is elevated, maybe this is not really normal. But there is no easy way to transform that to cortisol without estrogen.
Another question related to that. Is there anything about serum-free cortisol or salivary cortisol in such cases, patient on oral estrogen?
Well, certainly salivary cortisol can be used to rule out Cushing in patient oral estrogen because it reflects free cortisol, so it's not influenced by increase in CBG. Free serum cortisol can be measured, and I think eventually it's going to be probably routinely used. But as of now, there is no direct assay. It's an equilibrium dialysis assay, and at least here it takes about 2 weeks to come back. So often, you are left, particularly when you want to rule out adrenal insufficiency, you don't have that kind of time. To rule out Cushing, it can be used, and there is a couple of papers on the cutoff. I don't want to give you wrong numbers, but you can look it up. One paper from Dr. Hamrayan when he was at the Cleveland Clinic that used the free cortisol measurement to interpret the exopression test.
Amazing. Excellent. So there is also a question about the Mr. Malone test for growth hormone deficiency. Can it be done in patients with history of pituitary radiation therapy?
That's a very interesting, very shows sophistication, high sophistication of the person who wrote it. The answer is that. So what he or she is getting to is that massimorelin acts at the level of the pituitary gland. And if you have a post-radiation hypopituitarism, that's mostly a hypothalamic disease. So there is a phase in the first few years of radiation where you may be growth hormone deficient, but if you use a test that stimulates the pituitary directly, the massimorelin test or the GHRH plus arginine test, you may have a normal test, but still the patient may be growth hormone deficiency because that patient didn't have the time to develop atrophy of those somatotroph cells. This has been very well shown with the GHRH plus arginine test, showing that patients with recent radiation, a certain number of patients with recent radiation failed the ITT, but passed the GHRH plus arginine. And then eventually they failed also the GHRH plus arginine after 5 years. It hasn't been shown for the massimorelin test, but there is the theoretical possibility that yes, that could be the case. So I agree that if somebody had relatively recent radiation therapy, probably using a test that stimulates the whole system like insulin or glucagon is a better choice. But congratulations to the patient, to the person who asked this question. Shows high degree of sophistication.
Another question in regards to, they said why, I think related to one of the question of the growth hormone deficiency post-TPI, why to rely on growth hormone, not IGF-1, while growth hormone has diurnal variation? I don't think...
Well, we rely on growth hormone after stimulation. We don't rely on a random growth hormone. I mean, if you get a random growth hormone by any chance because the patient is stressed or is above 3 or 5, then probably you don't need it. But usually we don't rely on random growth hormone. So we use both IGF-1 and, if needed, a growth hormone stimulation test.
Another question for giant prolactinoma. How's your approach in starting cabergoline? Do you start a smaller dose and then titrate up, or the other way around, higher dose and titrate down?
Yeah, I usually start on a lower dose. I usually start on, I give patients, the first week I give patients, no matter what they do, I give half a tablet twice a week, just to make sure that they can tolerate the cabergoline, they don't get significant dizziness or nausea or vomiting. And then if they can tolerate, the second week I increase to twice a week, one full tablet twice a week. And then I get a prolactin level at a month, after a month, to assess their responsiveness. And then typically, if they are responding, I don't increase the dose until I get a plateau effect. I only increase the dose if the effect is a plateau. So my tendency is to start low and increase it only if needed.
Excellent, excellent. We'll take one question more. This is related to the duration of dopamine agonist treatment for prolactinoma. When do you consider stopping it, and what are the criteria to hold the treatment?
That's a super question. And sadly, we actually looked and published our data recently. The bottom line is that almost everybody needs long-term therapy, because the criteria for stopping that were suggested by the Pediatric Society is a low prolactin on a minimal dose of cabergoline. So let's say your patient is on 1 tablet of cabergoline a week, their prolactin is below 5.4, which is the cutoff that Dr. Colau group determined. That was what we call withdrawal condition. But only about 60% of patients get to those withdrawal condition. And then when you withdraw, the vast majority of those patients will recur eventually. It's safe to withdraw because increasing prolactin occurs way before any visible increase in tumor size. So it's safe withdrawal. But at the end of the day, in our series of nearly 300 patients, only about 9% of patients were able to come off Cabergon eventually.
Amazing. Thank you so much, Prof. Salvatore. It was an amazing session, and this was obvious from the interaction of the audience and the amount of the questions received. Thanks a lot, and wish to see you again.
Thank you, guys. Enjoy the next question. The next session is going to be great.
We are going into break now, and we'll start after 15 minutes. Thank you.
Good evening, everybody. Colleagues, we are continuing our 7th Gulf Endocrine Review course. This is the second lecture, and we are pleased to have with us Professor Shahzad Basaria. Professor Shahzad Basaria is an expert in the field of endocrinology. He is a professor of medicine at Harvard Medical School and associate director section on men's health, aging, and metabolism at Brigham and Women's Health and Women's Hospital. He is recognized leader in the field of male reproduction, and his work actually has contributed to the understanding of the cardiometabolic complication of androgen deprivation therapy in men with prostate cancer and efficacy of testosterone replacement in men with opioid-induced androgen deficiency, in addition to many actually in publication in this field. He is real expert, and he is also a friend of us here in the Gulf, and as he is always participating in our session, whether at GATE or other activities. So we are pleased to have him, and without further ado, and I hope you know me. My name is Ali Al-Ma'mari, and I work at Sultan Qaboos University Hospital, and also I am the past president of GATE. Currently, my colleague is Dr. Khalid Al-Dahmani is our president. So without further ado, Professor Shahzad Basaria, we are delighted to have you again and again. And I remember you was with us actually in 2019, physically in Muscat, Oman. So again, the review course with you here virtually. And so you are most please start your lecture. Thank you very much.
Thank you very much, Dr. Ali. I very much appreciate your kind introduction and want to thank organizers of this conference for their invitation. It is true that I have many friends in the Gulf, and it was a pleasure to meet everyone in person earlier this year, and look forward to meeting you in person in the future. I want to thank the audience as well for taking the time and joining today. Today's course summarizes various elements of male reproductive disorders. We have 16 questions, and after each question, I have some description or rationale in terms of why the correct answer is correct and why the distractors are incorrect. So without further ado, we can move to the first question. A 46-year-old man is referred for management of his primary hypogonadism. He initially presented to his provider 5 months ago with decreased libido. After appropriate workup, intramuscular testosterone cypionate, 200 milligrams every 2 weeks was initiated. His libido has improved, but he's bothered by mood fluctuations that occur a few days before his next injection. On physical exam, there is no gynecomastia, and there is some testicular atrophy of 13 cc's, as he has primary hypogonadism. Serum testosterone concentrations 1 week after the injection are around 600 nanograms per deciliter. His hematocrit is normal. So the question is, which of the following is the best next step in this patient's management in terms of his symptom fluctuation? A, change the current regimen to 300 milligrams every 3 weeks. Second, switch to testosterone enanthate at the current dose. C, change the current regimen to 100 milligrams every week. And D, to continue current regimen. You may now poll. Excellent. So indeed, the polling clearly suggests that most of you are in agreement that the correct answer for this question is indeed C, which is change the current regimen to 100 milligrams every week. This is important to appreciate when we manage our patients on testosterone treatment. I will take you first through some elements which are mentioned on this slide. And in the next slide, a figure will clearly show you the pharmacokinetics of testosterone therapy with different doses and different regimens. So B, switching to testosterone enanthate is incorrect because the pharmacokinetics of testosterone cypionate and enanthate is exactly the same. So just by changing the ester, you will not change the issue with pharmacokinetics. And D is incorrect because patient is really bothered by these fluctuating symptoms, and just continuing current regimen is not beneficial to the patient. Now, these are the pharmacokinetics of short-acting testosterone, either cypionate or enanthate. And if you look on the right side of 200 milligrams every 2 weeks, which this patient was receiving, as you can see that after the injection, testosterone level really peaks quite high, but then just before the next injection, it bottoms out and is very close to the lower limit of normal range. And even though you will see all these dots within the therapeutic range, it is the fluctuation that bothers many of our patients. And that's the reason this is not the physiologic dose, it is the dose of convenience, because with this, patients can only inject themselves twice a month, and we want to minimize the number of injections. One of the incorrect distractors was changed to 300 milligrams every 3 weeks. And as you can see, by doing that, not only the peak goes higher, but also the trough is even closer to the lower limit of normal range. And these fluctuations result in mood fluctuations as well. So the correct answer is to give more frequently, but at a smaller concentration, which is 100 milligrams weekly. And as you can see, it is a plateau, and all the levels are within the therapeutic range. This is the second question. A 48-year-old man presents with reduced libido and energy for 6 months. He denies head or testicular trauma. He underwent normal puberty. He is married, but does not have any children. He has a 6-year history of hyperlipidemia, which is controlled on atorvastatin 40 milligrams daily, and a 15-month history of lower back pain, which is being treated with a fentanyl patch of 50 micrograms. On physical examination, he is normally virilized, visual fields are normal, there's no gynecomastia, and normal genital exam with both testes 20 cc. Normal testicular size is 15 cc or greater. His total testosterone in the morning is 98 nanograms per deciliter, measured by mass spectroscopy. LH and FSH levels are inappropriately normal. As you can see, that they are very much in the lower limit of normal range. Prolactin is normal, so are the thyroid function test. His serum cortisol is robust, and iron saturation is normal as well. Pituitary MRI was performed since the patient gave a picture of central hypogonadism, but the MRI is also normal. So the question is, which of the following is responsible for the patient's hypogonadism? A, atorvastatin. B, Klinefelter syndrome. C, congenital isolated hypogonadotropic hypogonadism. And D, fentanyl patch. You can poll. Excellent. I'm delighted to see that most of you really recognize the root of the problem here, and this is opioid-induced hypogonadism, which usually present as a central phenomena. So you get a picture of central hypogonadism. And this is important to appreciate because many of our patients, young and middle-aged or older, are on high doses of chronic opioids, and they suppress GnRH synthesis and release, and you get a picture of central hypogonadism. Atorvastatin or any other statin has not been shown to decrease synthesis of sex steroids, even though they do lower cholesterol, and cholesterol is important in the synthesis of sex steroids, but it has not been shown to substantially decrease serum sex steroid concentrations. This is not Klinefelter syndrome because in Klinefelter syndrome, which is a primary hypogonadal condition, gonadotropins are elevated, and here gonadotropins were low normal. Furthermore, the testicular size was normal in this individual, suggesting that he has gone through appropriate pubertal development. And that's why it is also not Kallmann syndrome, which is C, isolated hypogonadotropic hypogonadism. So this is purely opioid-induced androgen deficiency. This is a classic slide, a paper by Dr. Mendelsohn a while back that had shown that people who are on methadone at the dose of 125 milligrams daily, testosterone levels can be really in the castrate range sometimes. And we see it in our patients who are on chronic opioids. And the teaching in medical school and during training always had been that once you reduce the dose of opioids, testosterone levels will rebound and normalize. That is true if your patient is on opioids for a short period of time. But there are patients who are on chronic opioids, and sometimes they never go off it. So that's why recognition of androgen deficiency is important in those individuals. And treatment with testosterone is also very much appropriate if those patients are going to be on opioids for a long period of time. The caveat being that opioid-induced androgen deficiency is a diagnosis of exclusion. You need to make sure that there is no other pathological reason for a person to have low testosterone. That's the reason measurement of prolactin, iron studies, MRI is extremely important. Now, most opioids that are mu receptor agonists are potent suppressors of gonadal axis, such as methadone, morphine, heroin. But if someone asks you that they are planning to start a patient on opioid and the patient is worried about low testosterone, is there an opioid that does not suppress the gonadal axis that much? And that is buprenorphine. So here you can see a study by Bleasner that had shown that people who are on methadone, quite a few of them have testosterone levels which are below the lower limit of normal. But testosterone concentrations in people who are on buprenorphine, which is an atypical opioid, is normal and comparable to control. And even when you look at symptoms of androgen deficiency, such as impaired libido or impaired potency, it is much higher in methadone users as compared to users of buprenorphine. So this is extremely important to keep in mind, that if you have a choice to start something, buprenorphine might be protective in terms of not suppressing gonadal axis. Question 3. A 32-year-old man presents for evaluation of infertility. Secondary hypogonadism was diagnosed 3 years ago after hypophysectomy for a non-functioning pituitary macroadenoma. He has been doing well on testosterone patch. He now desires a second child. Has been trying for 14 months without success. 2 semen analyses have revealed oligozoospermia. No other relevant medical history is there for us to ponder on. On physical exam, he is normally virilized. Testicular volume is 20 cc's bilateral. His testosterone on testosterone patch is 500 nanograms per deciliter. LH and FSH are, of course, low because the patient has undergone hypophysectomy. After discontinuing testosterone therapy, which is the most appropriate treatment option for fertility induction in this patient? A, start aromatase inhibitor. B, it should be starting subcutaneous GnRH pump. C, combination of HCG and FSH injections. And D, HCG injections only. Excellent. This was a tough question, and I'm so impressed that most of you have gotten the correct answer. And the correct answer in this case is, of course, starting HCG injections only. And the rationale for that I will summarize in the next few slides. So what I would like to do is give you an overview of the hypothalamic pituitary gonadal axis, or HPG axis. We know everything starts here in hypothalamus, where GnRH is produced. It comes down the pituitary stalk and acts on gonadotropes in the anterior pituitary. They make LH and FSH. LH stimulates Leydig cell of the testis to stimulate testosterone production. FSH acts on seminiferous tubules, and Sertoli cells to promote spermatogenesis. Now, the classic teaching has always been in medical school and in other literature that it is the testosterone that causes the negative feedback. But even in a man, it is aromatization of testosterone to estradiol that suppresses the gonadal axis. So let's look at the options that we had. One option was to start a GnRH pump. Now, of course, a GnRH pump is not going to work because this person has undergone hypophysectomy. The gonadotropes were damaged in the first place due to surgery. So what is GnRH going to do? Nothing, because there are no gonadotropes. So that's the reason this answer is incorrect. In terms of initiating aromatase inhibitor therapy, what aromatase, of course, aromatase inhibition does, it suppresses synthesis of estradiol, loss of negative feedback. You increase GnRH, LH, and FSH and stimulate testosterone production and spermatogenesis. But if the integrity of the HPG axis is not intact, either aromatase inhibitor or clomiphene is not going to work. Because even if you are giving aromatase inhibitor and increasing GnRH, there are no gonadotropes to work on or to act on. Now, the final two options were combination of HCG alone versus HCG and FSH. So this is extremely important to appreciate, that if central hypogonadism occurs in a post-pubertal state, just like this patient that we discussed, the infrastructure, the machinery of the testis has already developed. There are seminiferous tubules there, there are Leydig cells there. They are simply dormant because there is no gonadotropins coming down to stimulate them. So in such situations, when the infrastructure has developed already, just HCG does the job. And as you can see in this slide, look at the sperm count on the y-axis. This is the pre-treatment. Almost everyone was oligozoospermic or azoospermic. And HCG injections normalize spermatogenesis over the course of 3 to 6 months in these individuals. Now, if prepubertal onset is responsible for infertility, such as Kallmann syndrome or other pituitary conditions that person doesn't even undergo puberty, then we need help from both HCG and FSH. And even then, not all patients normalize spermatogenesis. And if your patient who has prepubertal central hypogonadism and was also born with cryptorchidism or undescended testes, then even combination of HCG and FSH would not work. Next question is of a 55-year-old man who comes for evaluation of increasing fatigue for the past 15 months. He reports morning headaches and daytime somnolence. He recently saw his doctor, who checked total testosterone, which was 284. He has normal libido. He has hypertension, which is controlled on hydrochlorothiazide. He's married and has 3 biological children. He is obese with BMI of 37. There are no classic features of Cushing syndrome. Visual fields are normal. He has acanthosis and thin pinkish abdominal striae. His testes are 20 cc's bilaterally, and muscle strength is normal. You check total testosterone again, and it is 290 nanograms per deciliter. Fasting glucose is 110. Serum cortisol is robustly normal, and so is hematocrit. So the question is, measurement of which of the following should be the next diagnostic step in this patient's evaluation? A is checking for iron saturation, B, gonadotropins, C, free testosterone, and D, prolactin. You may poll. Excellent. So I like this spread, but most of you have gotten the correct answer, which is checking free testosterone. And I think this is very important to appreciate that when a person presents to you who is obese or has other conditions in which you suspect SHBG fluctuations, then one has to rely on measurement of free testosterone. Iron saturation measurement, checking for gonadotropins, checking for prolactin, of course, are important steps in getting to the root of the diagnosis. But before embarking on these investigations, you have to make sure that you are crystal clear in terms of diagnosis of androgen deficiency. This person has a BMI of 37. When you have these high BMIs, SHBG levels are on the lower side, and total testosterone can be spuriously low. And that's why free testosterone measurement is extremely important. These are data from Dr. Zumoff from a while back in a classic paper showing that obese men compared to normal weight controls have low total testosterone, and mainly due to low SHBG. In majority of the patients in whom the BMI is less than 40, free testosterone is still normal. Only when you become morbidly obese, free testosterone may also decline, which is apparently an adaptive response. And I will mention that to you in the future slide. And this is the reason that SHBG levels are low. Insulin resistance, which is a common problem in obesity, and this patient had it because he had acanthosis nigricans, suppresses SHBG synthesis in the liver. So if you look at a cultured human hepatoma cell line and look at the measurement of SHBG production in that cultured medium, this is the basal production of SHBG. Addition of thyroid hormone increases it. But when you add insulin to the medium along with thyroid hormone, SHBG production goes down. If you just put estradiol, we know that it enhances sex hormone binding globulin production. But when you add insulin along with estradiol, again, there is suppression of SHBG production. So that's the mechanism. But what's important for the audience to appreciate is that this is an adaptive response. There's nothing wrong with the integrity of the hypothalamus, pituitary, or testes in these obese patients. And the reason I say that is weight loss by any means results in rebound normalization of serum testosterone. So this is a beautiful summary slide from JCNM from 6 years ago. Each circle is a clinical trial. Size of the circle reflects the sample size of that trial. White circles are those studies in which patients were randomized to diet or exercise or medications. And gray circles are those studies in which patients underwent a gastric bypass procedure. And as you can see, more weight loss you experience, more is the delta change of testosterone, which suggests that this is an adaptive response. And if you have a patient who is presenting with these symptoms, perhaps good to guide them in the direction of weight management. Because if you start them on testosterone, I'm not sure what the end point is going to be. That's why it is important to look at the total situation with closed eyes And the daytime somnolence that this patient was experiencing and fatigue could be because of underlying obstructive sleep apnea. In terms of measurement of free testosterone, gold standard is equilibrium dialysis, which I appreciate is not available in many centers. If you do not have equilibrium dialysis method available, calculation of free testosterone would suffice. And on the next slide, I will mention how to calculate it. What I would strongly discourage you is to ask your hospital lab to measure free testosterone, because they use analog assay, which can either under or overestimate free testosterone by 15 to 20%. So that is highly unreliable. So if you don't have equilibrium dialysis, calculate yourself, and you can do it on your desktop. If you Google free testosterone calculator, this will appear. You need to have total testosterone by good method. If mass spectrometry is available, that's great. You have to measure SHBG, and you can measure albumin or put a constant of 4.3. And then when you click the calculate button, you will have free testosterone available. It is debatable what the cutoff is. Many people think it's 50 picograms per ml. Some people think that 70 picogram per ml should be the cutoff. But you have to take this in the totality of picture of how your patient is presenting. A 24-year-old man is referred for evaluation of delayed sexual development. He grew normally as a child, but did not experience an increase in size of his phallus or testes. His sense of smell is normal. He was not a good student, performed poorly in sports. He does not take any medications. He has never taken anabolic steroids. He has a low hairline and a high-pitched voice. He has unicoidal habitus because his arm span is more than 5 centimeters longer than his actual height. Visual fields are normal, no cleft palate, faint axillary and chest hair, bilateral gynecomastia, 10 or 2-stage pubic hair, micropenis, and testes are only 4 cc's. He has reduced muscle mass, no mirror hand movements or synkinesis. Total testosterone is 52. LH is suppressed and FSH is also inappropriately low. Thyroid function tests are normal. Which of the following is the most appropriate diagnostic test to perform next? A, pituitary MRI. B, measurement of free testosterone. C, GnRH stimulation test. And D, perform karyotyping. So this is a good spread, and whenever there's a spread like this means there's an opportunity to learn, an opportunity to teach. The correct answer here is to obtain a pituitary MRI. Karyotyping is performed, of course, to look at chromosomal alterations and generally done in patients who have Klinefelter syndrome. And in Klinefelter syndrome, gonadotropins are elevated. So this is something which is not indicated in this patient. Similarly, measurement of free testosterone, which no one chose, is not important because total testosterone is so low that you don't even need to worry about any changes in free testosterone. This patient provides a picture of Kallmann syndrome, right? Central hypogonadism. And some of the features, difficulty learning, difficulty in school, all those things suggest clearly that he might have a genetic cause for central hypogonadism. But prior to doing any genetic testing, which is not even mentioned as an option, you have to ensure that there is no structural lesion in the pituitary that has resulted in this prepubertal hypogonadism. Because you will see many cases in which these kids do have large adenomas, which may not have caused symptoms of mass effects, but has hindered their growth and development in one hormonal domain versus the other. So I think this is simply a teaching point, just like we talked about opioids, that before embarking on more rarer things or more sophisticated things, it is important that we do not forget to exclude structural reasons for central androgen deficiency. Next question is of a 27-year-old man who is referred for evaluation of infertility. He has been having unprotected intercourse for the past 2 years, appropriately timed around his wife's ovulation. His wife's workup is normal. He underwent normal puberty and reports normal libido. His sense of smell is normal. He is normally virilized, BMI is 26, visual fields are normal, there's no gynecomastia, and testes are 15 cc's. His total testosterone is 486. FSH is elevated at 22. LH is normal. His inhibin B, which is made by Sertoli cells, are undetectable. Karyotype, 46XY, so normal karyotype. 3 semen analyses show azoospermia. Fructose is positive. And fructose, of course, suggests whether there is obstructive azoospermia or not. If it is positive, this means that there is no obstruction. Testicular biopsy reveals Sertoli cell only syndrome. Which of the following genetic abnormalities is this patient is most likely to have? A is Klinefelter syndrome, B, mutation in the CAL1 or Kallman gene, C, activating mutation in the kisspeptin receptor gene, and D, Y chromosome microdeletion. Great. So most of you honed in on the Y chromosome microdeletion, and it is indeed the correct answer and what I would do. Important to appreciate that after Klinefelter syndrome, Y chromosome microdeletion is the second most common genetic cause of infertility. This is not Klinefelter syndrome because of several reasons, but one, gonadotropins are not elevated in combination. LH is completely normal, FSH is high, and LH, even in people who are mosaic for Klinefelter, is on the very high normal side. The other thing which is extremely important is that testicular volume was 15 cc's. Klinefelter patients do not have that. This is not Kallman syndrome because gonadotropins are not low. And of course, testicular volume does not suggest Kallman syndrome. So you won't go for CAL1 gene. Activating mutation of the kisspeptin receptor gene is rare and it presents as precocious puberty in kids, which is not the case with this man. So he has Y chromosome microdeletion, and on Y chromosome, there are certain genes, azoospermia factor A, B, and C, deletions of which can result in selective inhibition of spermatogenesis. Testosterone levels in these men are normal. They are normally virilized. And since testosterone causes feedback mainly for LH, LH is nicely regulated, but inhibin B, which is made by Sertoli cells, which are dysfunctional, and so are the seminiferous tubules in this case, there is no inhibin, and that's the reason it does not suppress FSH, and FSH is elevated in isolation. These patients, sometimes fertility has been reported in people in AZFC mutation, and you can do testicular biopsy to isolate sperms, but one has to make sure that you perform genetic counseling. In AZFA and AZFB, you hardly find any sperms on testicular biopsy as well. So this is important to keep in mind when you see patients like that in your clinic. 78-year-old hypogonadal man presents to discuss potential side effects of testosterone therapy. He developed primary hypogonadism after receiving chemotherapy for lymphoma. Medical history notable for benign prostatic hypertrophy and coronary artery disease, for which he had stent placement 3 years ago. Total testosterone is low, only 110. His PSA is 2.9, hematocrit is 45%. His prostate is symmetrical and mildly enlarged, but no nodules. Which of the following adverse events or adverse effects is most likely to occur during testosterone replacement in this patient? A is acute myocardial infarction, B, PSA elevation above 4, C, urinary retention, and D, erythrocytosis or polycythemia. Excellent. So most of you have chosen polycythemia, which is the correct answer. And indeed, this has been known for a long time that testosterone impacts pluripotent stem cells in the bone marrow and sort of transforms them towards erythroid lineage rather than myeloid lineage. And before erythropoietin, androgens were being used for the treatment of various types of refractory anemias, including anemias that resulted from cancer therapy or bone marrow depression. Let me take you through the distractors first. There have been no evidence, especially after a publication of the Traverse trial earlier this year, that folks who participate in clinical trials and are randomized to testosterone compared to placebo have a higher risk of acute myocardial infarction or any other major adverse cardiovascular event. It had always been controversial, but after the publication of the Traverse trial, our sort of confidence is increasing that testosterone may not be that harmful from the cardiovascular perspective. PSA elevation does occur to some extent when you start a hypogonadal man on testosterone, because prostate is an androgen responsive organ, and in hypogonadal state, of course, PSA is not being produced to its fullest potential. And when you replete these patients with testosterone, of course, there is going to be some more production of PSA, and we are going to talk about that in a question later on. But we do not see, and clinical trials have not shown that this is more common in men who are on testosterone compared to placebo, because older men also have subclinical prostatitis, which might result in leakage of PSA in the circulation. Urinary retention has not been shown in any study to be higher in men on testosterone versus placebo. Now, when you look at various testosterone trials and look at meta-analyses of these trials, if there is a single side effect which we see more often, of course, is polycythemia. More than prostate events, more than PSA increasing above 4, certainly more than prostate cancer, which also has not been shown conclusively that is caused by testosterone therapy. So this is something which is a common problem, and I'm sure you encounter in your clinic. These data from Adrian Dobbs a while back had looked at the incidence of testosterone-related erythrocytosis in men who were in transdermal testosterone patch group versus intramuscular testosterone injections. And as you can see, more men who got intramuscular injections became polycythemic, but these men were getting doses of 200 milligrams every 2 weeks, like the first question that we had, which results in much higher peak. By giving 100 milligrams a week to younger men or 75 milligrams a week to older men, you can avoid incidence of polycythemia as well. So I think it is important to appreciate that this can still happen. It can happen more in older men compared to younger men because the metabolic clearance rate of testosterone goes down with age. But still, if you give 100 milligrams a week or 75 milligrams a week, you can avoid all these incidences that I'm displaying here. But good to keep in mind that still polycythemia should be at the back of your mind as the most common side effect. A 35-year-old man presents with infertility. He has been having unprotected intercourse for 2 years. Patient reports normal sexual function. His wife has 1 child, but by a previous marriage. She has regular cycles. The patient denies using anabolic steroids and says his testicular size has not changed. He has normal secondary sexual characteristics, no gynecomastia. Testicular volume is 25 cc's bilateral, so robustly normal. But on exam, the vasa differentia, the vas difference, were not palpable on either side. Total testosterone is normal at 450. Gonadotropins are normal. Prolactin is normal. You do a semen analysis, and it showed that the volume is reduced, only about 1.8 cc's. pH is acidic. Usually it is more on the basic side. Fructose is negative. And of course, there is azoospermia. You cannot see any sperm. Which of the following is the most appropriate next step? A, perform a CFTR or cystic fibrosis gene genotyping. B, DAX1 genotyping. C, testicular biopsy. And D, clomiphene citrate therapy. Excellent, superb. So majority of you have chosen doing CFTR genotyping, and that indeed is the correct answer. And it is important to appreciate that as far as cystic fibrosis gene penetrance is concerned, it presents in various ways. Of course, the pulmonary condition is something that we have learned and known a lot. But what is unclear to many trainees is also that there are subtle manifestations which present like this patient has, which is infertility. And what happens is that there is maldevelopment or agenesis of a vas difference. Sometimes vas difference is present but ends blindly. So the manifestations are variable. DAX1 gene mutation presents not only with hypogonadism, but also with adrenal insufficiency, and that is not the phenotype in this patient. Testicular biopsy will not be the answer here because on biopsy you will find sperms. The problem here is the transport of the sperms. And of course, clomiphene citrate, which has not been approved for anything as far as men are concerned, is not the correct answer. So this is the anatomy of a normal male, and you can see here testis with seminiferous tubules. You have the epididymis, the caput of the epididymis, the head, the body, and then the tail of the epididymis, and then it continues into vas difference. This is what happens in men who have CFTR mutations. Not all of them, depending on the penetrance, but this is one of the major manifestations in some patients, that there is caput of the epididymis, which is much more engorged as compared to normal men. But then there is aplasia of vas difference, and the epididymal tail ends blind. So in these patients, of course, who desire fertility after appropriate counseling, you can always retrieve sperms by testicular exploration. But making the diagnosis after your physical exam would be to go and get CFTR gene mutation. And this is something which was also performed in the patient that I mentioned, which we had seen in the clinic. A 32-year-old man presents with an 8-year history of rapid ejaculation during intercourse. During most sexual attempts, he ejaculates within 30 seconds of penetration. His libido and erections are normal. He has no history of pelvic surgery or prostatitis. He does not have depression. He has tried the stop-start technique to delay or prolong the process of intercourse, but it has not been successful. He is married and has 1 child, and he does not take any medications. He is normally virilized. Normal phallus without curvature or palpable plaques means no Peyronie's disease. Testes are normal, and so is the prostate. Testosterone is around 680, and thyroid function tests are normal. Which of the following is most likely to help his condition? A, starting paroxetine or Paxil. B, finasteride. C, application of eflornithine cream on glans penis. And D, Lupron injections. Great, I like this spread, and I also like that most of you have chosen paroxetine, which is indeed what I would do and is the correct answer. What this patient has is premature ejaculation. We always talk about decreased libido. We always talk about erectile dysfunction. The third common disorder that men also experience is premature ejaculation, defined as ejaculation less than 60 seconds after penetration. And this person truly was an advanced case of premature ejaculation. Finasteride does not help. It only inhibits, as you know, conversion of testosterone to DHT, and DHT has not been shown to have any role in terms of erection or premature ejaculation, so that won't help him. Eflornithine cream is given to women who have hirsutism due to PCOS or idiopathic hirsutism. It's local cream that you apply on the face, and there's no indication to use it in this condition. I should mention that sometimes lidocaine cream has been tried on glans penis to decrease the sensitivity of the glans penis so that the intercourse can be prolonged, but that also results in anesthesia of the vaginal walls, and that is not acceptable to the partner. So that's the reason that lidocaine cream have fallen out of popularity. And by suppressing this man's testosterone will not solve the problem of premature ejaculation. It has no correlation with circulating serum testosterone concentrations. So either you can use any SSRIs on demand, or you can also use it as prolonged therapy. So usually I recommend my patients to take it on demand. So taking, say, for example, paroxetine, which was the answer to this question, ranging from 10 milligram to 40 milligram, 3 to 4 hours prior to intercourse. Similarly, sertraline can be done at these dosages as well, a few hours prior to intercourse. So just like when we give Viagra or Levitra or Cialis or any PDE5 inhibitors and try to time it from the time of planned sexual activity, same thing can be done with SSRIs in patients who have premature ejaculation. A 76-year-old man on testosterone replacement returns for follow-up visit. He was first seen 9 months ago with reduced libido and low energy. At that visit, morning testosterone was 218 and his PSA was 1.2. His prostate exam showed that it was symmetrically enlarged without nodules. You started him on testosterone gel, 40.5 milligram, which he has been applying for 6 months now. His libido and energy have normalized. He denies lower urinary tract symptoms. His prostate exam remains unchanged at this visit as well. Testosterone on treatment is nicely normal at 460. His PSA now is 3.2. It was 1.2 at baseline prior to starting treatment. You ask him to come back after 5 days and repeat PSA, and it is still 2.9. Which of the following is the best next step in this patient's management? A, refer to a urologist. B, reassure and schedule follow-up in 6 months. C, reduce the dose of testosterone gel to 20.25 milligrams daily, half the dose of what he was applying, or start a 5-alpha reductase inhibitor now along with continuing current dose of testosterone. Okay, again, I like this spread, and it looks like that the main tussle is between A and B. So this is important. And again, it provides us with a teaching opportunity. The correct answer here is the A, which is referred to a urologist. And I will explain why B is incorrect in the next couple of slides. But first, to make sure that I address C and D, there is no reason to reduce testosterone gel. On the starting dose, which was 40.5 milligram, which is 2 pushes of testosterone gel pump, his levels were therapeutic, around mid 400s. If you decrease it, the levels are going to be subtherapeutic. So that does not solve the problem. He's feeling better, his levels are therapeutic. We have to address the issue of the PSA at this time. So reducing the dose does not solve that problem. And starting a 5-alpha reductase inhibitor is incorrect because he does not have any urinary symptoms. It's basically the PSA that has gone upwards since initiation of testosterone therapy. So that is not helpful as well. So the reason B is incorrect is to provide you with context. When we see patients in clinical trials who get enrolled, either young men or older men, when we initiate testosterone therapy, in 6 months or so, the delta change in PSA in young men is around 0.3 nanogram per ml. In older men, around 0.45 nanogram per ml. So suffice it to say, it doesn't matter how old the patient is, the delta change is less than half a nanogram per ml, irrespective of the age group. Now, if you look at on the right side, we also need to understand what is the natural fluctuation in PSA levels in people, in the population. So when you look at data in men who are not on any treatment, just follow their PSA levels periodically year after year, within a year's time frame, the upper limit of confidence interval equates to 1.4 nanograms per ml. This means naturally, because of various issues, subclinical prostatitis, the PSA can change as much as 1.4 nanogram per ml from when you had seen the patient before. And that's the reason Endocrine Society guidelines suggest that when on testosterone therapy, your patient's PSA is beyond 1.4 nanogram per ml, that cannot be explained by natural variation. And of course, this is not what has been seen in clinical trials. This patient, if you remember, started with a PSA of 1.2 and then went up to 3.2. So it was a delta of around 2 nanogram per ml, much greater than 1.4. So here we recommend these patients to go and seek urologic consultation. This does not imply that they have prostate cancer. This simply means that we need to do something to make sure that there is nothing occult sitting in the prostate that might have gotten exacerbated with testosterone therapy. Once prostate evaluation is complete and the urologist is happy and gives you a green light, then you may resume testosterone therapy in these individuals. Otherwise, we take a pause, we send them to urologists. Once they come back, you reinitiate therapy. A 37-year-old man presents with low libido and loss of morning erections. He denies head or testicular trauma. He's married and has 3 children. Inflammatory arthritis was diagnosed 6 months ago, and he was started on TNF-alpha inhibitor or biologic, along with high-dose prednisone. His prednisone is now reduced to 20 milligrams a day 3 months ago, so he was on high dose for some time. He has facial plethora. His BMI shows that he's overweight. Visual fields are normal. Testicular size is also normal. There's, of course, swelling of the small joints of the hands. His total testosterone in the morning hours is 134. Gonadotropins are inappropriately normal. Prolactin is 16. TSH and IGF-1 are normal. His glucose is 112. Transferrin saturation is 36. Pituitary MRI was performed to rule out a central lesion, and it shows a 3-millimeter adenoma. Which of the following is responsible for this patient's androgen deficiency? A, pituitary adenoma, B, TNF-alpha inhibition, C, hemochromatosis, D, prednisone. Excellent. I again like the spread, but the correct answer was chosen by the majority of the attendees, and it is indeed prednisone. And this is the case of glucocorticoid-induced hypogonadism, which, just like opioid-induced hypogonadism, provides a central picture because high-dose glucocorticoids suppress GnRH synthesis and release just like opioids do. And these patients present with inappropriately normal or inappropriately low gonadotropins in light of low testosterone. It is also a diagnosis of exclusion, that you need to make sure that there is nothing organic ongoing before you attribute this low testosterone to glucocorticoid use. This pituitary lesion is 3 millimeters. It's likely an incidentalloma, and this should not be resulting in this profound androgen deficiency. Biologics such as TNF-alpha inhibitors do not result in hypogonadism. The reason it is not hemochromatosis, and I'm really very happy that many of you chose hemochromatosis, because we should not forget this diagnosis in a man who presents with hypogonadism. But the transferrin saturation was around 32 to 34%. The first positive screening test that we get, which is transferrin saturation, if it is 45% or higher, that's the first indication that we have to go in this direction. But I'm happy that you are thinking about that. But also, please think about glucocorticoid-induced hypogonadism. These data from New Zealand a while back, this is the classic paper that had shown that testosterone levels in men who are being treated with glucocorticoids are much lower than age-matched controls. And the glucocorticoid dose is inversely proportional to your testosterone concentrations. Higher you are on, lower your testosterone is. But again, it's a diagnosis of exclusion. And if your patients are on glucocorticoids for a longer period of time and are hypogonadal, you may consider testosterone therapy in them, just like the opioid population. A 17-year-old boy is referred for evaluation of bilateral breast enlargement. He first noticed breast enlargement 11 months ago. His breasts increased in size for 8 months and then stabilized. Breasts are non-tender. He occasionally experiences nipple sensitivity. No galactorrhea, normal growth pattern. He takes no medication. He does not use anabolic steroids. He is well developed. He has some facial and back acne. Both breasts reveal rubbery, mobile, subareolar glandular tissue. No discharge or discoloration from the nipples. Genital exam reveals normal phallus and testis, which is at the moment 13 cc's bilaterally, and sexual development still Tanner age, stage 3. Which of the following is the best next step in this patient's care? A is reassurance and observation. Just follow him up. D is obtain a mammogram. C, perform karyotyping. And D, check urinary testosterone to epitestosterone ratio. Excellent. So most of you chose reassurance and observation, which I would do as well. And that is the correct answer. This is a patient who is experiencing pubertal gynecomastia. It's bilateral, it's symmetrical. There's no concern in terms of any malignancy. So mammogram is not indicated in this patient, nor is karyotyping. His testes are growing, already 13 cc's. They will increase in size. These are not Klinefelter testes, and the gonadotropins are not elevated. And there's no indication. The mild acne these boys have, this does not mean that he is using anabolic steroids. So reassurance and observation is the way to go. And I think to make this case, I have chosen a paper to show you from 1961, published in JAMA, that looked at a group of boys who had presented with pubertal gynecomastia just to see the natural history of pubertal gynecomastia. So at the first visit, around 3/4 of boys had some degree of gynecomastia. When the same group of patients were brought back a year later, this had decreased to a prevalence of 24%. And in the third year, it had gone down to 7%. So pubertal gynecomastia resolves in majority of the boys. There are minority of the boys who continue to have what we call persistent pubertal gynecomastia. Sometimes it even extends into the adulthood. But that is a different condition, and if there are concerns, one can appropriately guide them for treatment. But in this young boy, waiting and observation is the right approach. A 35-year-old man presents with 5-month history of decreased sexual desire and tender breast enlargement. He takes no medications, no weight loss or nausea. He does not take any performance-enhancing drugs. He's well virilized, normal BMI. Thyroid gland is minimally enlarged. He has 5 centimeter bilateral tender gynecomastia. Testes are 15 cc's bilaterally. There are no palpable masses. His total testosterone is only 79. His estradiol is 180 picograms per ml. For those of you who may not be aware, the normal range is 10 to 50 picograms per ml in a man, and majority of us live around 25 to 30 picograms per ml. His gonadotropins are suppressed. His TSH is mildly low, and prolactin is 18. Which of the following is the most likely diagnosis in this patient? A is abuse of tetrahydrogestrinone, which is one of these SARMs. B, Sertoli Leydig cell tumor of the testis. C, choriocarcinoma of the testis. And D, thyrotoxicosis. Okay, so there's a spread as well, and most of you chose A, but the correct answer here is B. So this is one of those circumstances which are rare, but patients who do have estradiol producing tumor of the testis result in profound gynecomastia, which is rapidly enlarging and tender, and it suppresses testosterone. As I had mentioned about the HPG axis, it's estradiol that suppresses the gonadal axis, even in a man. So this is what we are seeing here. These tumors are not palpable because they are small but highly functional. So you have to perform sonogram of the testis in order to find these lesions, and then they can be resected. It is not thyrotoxicosis. Indeed, very rare presentation of patients with Graves' disease could be gynecomastia, but then they have to have profound Graves' disease, so much so that SHBG levels go up. There is lots of bound testosterone on SHBG, but the free testosterone falls, and there is mismatch of the testosterone to estradiol ratio. That's the mechanism. But his TSH is just mildly suppressed. Choriocarcinoma, which is HCG, producing tumor of the testis, it acts on the Leydig cells to increase testosterone production, which then gets aromatized to estradiol and results in gynecomastia. So both testosterone and estradiol are elevated in those patients. Here you are seeing isolated estradiol elevation, testosterone is suppressed. Tetrahydrogestrinone is a SARM which is not aromatizable. So what it does, it suppresses endogenous testosterone. And of course, if endogenous testosterone is suppressed, endogenous estradiol should be suppressed as well. So this is not the picture that you see with this type of abuse, because both testosterone and estradiol would be low, along with low gonadotropins in those individuals, because they are abusing a substance which cannot be assayed by regular means. You have to order an assay to measure tetrahydrogesterone. So here, Sertoli Leydig cell is the answer. These are some examples of the tumor. And many of these Leydig cells in such conditions have these crystals. They are known as crystals of Reinke, which are pathognomonic histologically. A 32-year-old male nurse is referred for low testosterone. He complains of low sexual desire and fatigue. He has an 11-year-old daughter from a previous marriage. He denies taking anabolic steroids. Normally virilized, normal BMI, no gynecomastia, testes are 18 cc bilaterally, and the muscle strength is normal. Total testosterone is low at 130. LH and FSH are also inappropriately normal. CT of the sella turcica is performed, which is normal and did not show any large masses. Which of the following is the most appropriate next test in this patient to get to the root of the diagnosis? A is measure serum prolactin, B, serum testosterone to epitestosterone ratio, C, chromosomal analysis, and D, perform an MRI of the sella turcica. Excellent. So most of you chose A, which is correct, to measure serum prolactin. This is bread and butter endocrinology. You have a patient presenting with low testosterone, is symptomatic, and along with low testosterone, gonadotropins are inappropriately low. I think we have to make sure that we exclude the possibility of prolactinoma, and we have to check serum prolactin. He had only gotten CT of the sella turcica, which can, of course, exclude macro adenomas, but still this patient could have a micro prolactinoma. And as we can see, we cannot ignore the power of prolactin. Even if it is elevated to some degree, it can suppress the gonadal axis. So that's the first next step. There is no reason to do chromosomal analysis in this individual. We do not see any hint of either Kalman-Klinefelter. He has a child. His testes are around 18 cc's. And there's no indication that he is taking testosterone abuse that is resulting in this phenomenon. There's no indication in his history, apart from his profession, that he's a male nurse, but does not necessarily implies that he's abusing it. This was a patient of mine when I was in Baltimore who had come with a picture of a profound hypogonadism as well as symptoms of mass effect. So it's a different patient than the case that I presented, but I did check for galactorrhea, and you can see it in a man as well. And of course, this patient had a huge macroprolactinoma, and this would be visible on CT of sella turcica as well. But the point I'm trying to make is measurement of prolactin is important, because if it is hyperprolactinemia-induced hypogonadism, management is different. You will go towards dopamine agonists rather than just repleting testosterone. So important to keep in mind. A simple case, but I think very enlightening. A 43-year-old man with HIV presents with 2-year history of fatigue and reduced libido. He has noticed decreased testicular size and decreases shaving frequency. So, specific symptoms. He's married and has 3 children. His CD4 count is currently normal, but had been low in the past with multiple opportunistic infections. He states that he does not use anabolic steroids or aromatase inhibitors. Is normally virilized, BMI 27, no gynecomastia, normal visual fields, and testes are actually atrophic at 12 cc's. Total testosterone was robust at 900. LH and FSH are also high, 19 and 30 respectively. TFTs are normal. Cortisol is also robust. You repeat testosterone a few days later with mass spectrometry, and it is similar to what you got by radioimmunoassay, around close to 900. Which of the following is the best next diagnostic step in this patient's evaluation? A, evaluate for depression. B, check urinary testosterone to epitestosterone ratio. C, genetic testing to exclude partial androgen insensitivity syndrome. And D, free testosterone measurement. Excellent. So most of you have chosen the correct answer, which is measuring free testosterone. Here is the reverse situation that we had discussed before, which was obesity-related low SHBG. In patients who have HIV, patients who have liver disease, and patients who are on various anticonvulsants, SHBG can be spuriously high. And when the SHBG levels are high, total testosterone can be artifactually normal. And here is a patient who is presenting with clear-cut symptoms of androgen deficiency. Not only decreased shaving frequency and decreased libido, but also there is some degree of testicular atrophy. So here you have to think about that unlike in obesity, where you are more likely to erroneously diagnose a patient with hypogonadism if you only rely on total testosterone, here you may miss the diagnosis of bona fide androgen deficiency if you just rely on total testosterone. And that's why free testosterone measurement is important whenever you see patients with conditions that result in SHBG fluctuations. Evaluation of depression might be okay, but not to get to the root of this problem. He does not appear to have partial androgen insensitivity syndrome. He has fathered a child, and the overall history clearly suggests that something happened during the course of his disease process. And no indication to suggest that he is abusing testosterone, because if you saw his gonadotropins, which were elevated, if a person was abusing testosterone, gonadotropins would be suppressed. Last question. A 40-year-old medical assistant is referred for evaluation of low serum testosterone. He reports decreased libido and fatigue. Has a 12-year-old child from previous marriage and no children from current wife. Does not take opioids or anabolic steroids. He reports arthralgias in both hands that limit his ability to work on the computer. Normal development sexually, no gynecomastia, testes are 15 cc's and normal muscle strength. Testosterone is 140, LH and FSH are low normal, giving a central picture. Prolactin is normal, and so is pituitary MRI. But the x-rays of the hands reveal chondrocalcinosis of the small joints bilaterally. Which of the following tests is most likely to lead to this patient's specific diagnosis? A, serum transferrin saturation. B, urine toxicology for opioids. C, serum T to epi-T ratio. Or D, genetic testing for Y chromosome microdeletion. Excellent. This is wonderful. And I think you have exactly come to the possible diagnosis of underlying hemochromatosis, because here we are talking about chondrocalcinosis. That's the picture that this patient was presenting. And I'm glad, and I wanted to put in mild hyperglycemia in the labs, but decided to test your knowledge without mentioning that. And I'm so glad that most of you recognize this. So this is hemochromatosis that we must exclude in these patients. There's no evidence that this person has Y chromosome microdeletion. He is a father, already has fathered a child. Nothing to suggest that he is a testosterone abuser. And opioids, of course, is something that you may think about when you're talking about a medical personnel, but that is something which is not manifested in his history, and his chondrocalcinosis reflects it. So this is the picture of patients who present with hemochromatosis. If you look at this knee joint, there's this calcification of the cartilage. You can see faint calcification here as well. So these are the patients that we must exclude hemochromatosis as a cause of central hypogonadism. I will pause here and turn it over to Dr. Ali, and again want to thank the organizers and all of you in inviting me and attending this presentation.
Thank you, Professor Shahzad. It was really very, very well concise, and the tone and everything is good learning points, صراحة. So we are just 15 minutes before the next session, and I have many questions for you. So I'll start immediately, please. What about testosterone and deconate libido? Everything can case also cause mood disturbance.
Mood
Mood
actually.
disturbance.
No, I think this is the advantage that testosterone undecanoate has, because even though it is injectable and a high dose is injected, it is slowly released into the circulation from its muscle depot. And that's the reason that there is no mood fluctuation, because there's a plateau. That's how it is released.
Thank you. What is the indication for gonadotropin releasing hormone stimulation test?
Not much, not many. In fact, in many centers, GnRH is not even available. In the past, it was being used to differentiate people who presented with central hypogonadism to see whether it is hypothalamic or pituitary. But even then, the responses were variable. So at this stage, there is none, and even GnRH replacement in people with Kallmann syndrome is no longer available because the drug is no longer available in many centers, apart from research settings.
Okay, thank you. How would you approach functional hypogonadism in males? Is low dose testosterone appropriate to use as treatment?
It's a very good question. And I think the main thing is to recognize that just like we have seen so many female patients with eating disorders as well, functional hypogonadism due to low caloric intake is also seen in men. And there, the approach is, of course, to increase energy balance and try to make sure that their own axis recovers. If this is not possible for a prolonged period of time with psychiatric help or nutrition help, then of course one should consider testosterone therapy, just like we do estrogen therapy in women with eating disorders.
Okay, thank you. What about the effect of new medication for erectile dysfunction, which is called Revita Prost? Are you aware about this?
Yes, it has just become available, but our clinical experience with this medication is rather limited because I do not think that it has even made it to our hospital formulary. But I must say that PDE5 inhibitors are highly effective in patients who have ED. So head-to-head comparison is a little bit different or not possible at this time. But once this medication comes and it becomes available to our pharmacy, we will try it. But for us, PDE5 inhibitors work really very well.
How it works, this medicine, new drugs?
It is.
What is the mechanism of action? In short, yes.
It works locally by increased vasodilatation. So it is more somehow acts at the level of cyclic GMP and cyclic AMP at the level of the penile tissue. So it is different a little bit as compared to PDE5 inhibitors in terms of more systemic advantages that it has, because PDE5 inhibitors are also used in the treatment of BPH, especially tadalafil, and also in primary pulmonary hypertension. But this is more restrictive in terms of improving just genital responses.
Thank you. Which points in history or physical exam are alarming to go for genetic study of hypogonadism? Which thing will let you told?
Yeah. So one thing, I mean, the overall clinical picture is important, right? If a person is presenting with significant testicular atrophy or has not developed testicular enlargement and has hypogonadism, then depending whether they have primary or secondary, you can decide which type of genetic testing you need to perform. Karyotype for Klinefelter syndrome or CAL1 gene or other genes for central. Also, some other features such as anosmia or hyposmia. If the sense of smell is impaired, again, you are thinking about Kallmann syndrome and other central causes. people who have synkinesis or mirror movements or difficulty in learning and understanding, they can be Kalman, and also behavioral issues and learning disability, along with primary hypogonadism and Klinefelter. So you have to take into account the whole picture and then decide what type of genetic testing. And sometimes it is isolated infertility in a person who is completely virilized with normal testicular volume and presents with oligozoospermia or azoospermia. So there you think about Y chromosome microdeletions to figure out why a person is infertile. So all depends on the clinical context.
The next question, what is the treatment for Y microsomal deletion?
The
microdeletion in
Y chromosome.
Yes.
So why measure?
What is the treatment? What is the treatment? Is there treatment for it? Okay.
Understood. Yes. So, I had mentioned on the slide that the three types of mutations that you have, AZFA, AZFB, AZFC. AZFA and AZFB mutations are not associated with spermatogenesis at all. So there is no treatment there apart from, of course, adoption and other guidance. AZFC results in oligozoospermia, and after appropriate genetic counseling, of course, you can think about either ICSI, which is intracytoplasmic sperm insemination after extraction. So you can do that. You can also, if a person has oligozoospermia, you can take the sperm concentrated and you can also use it in intrauterine insemination. So it depends what type of Y chromosome microdeletion they have, and only AZFC mutation has been associated with paternity.
I have two more questions. Many healthy young with no disorder or depressions have normal testosterone but complaining no libido. What is your thought on this? So just they don't feel the desire. Maybe.
But the testosterone is normal.
Looks like normal testosterone. Okay. Everything is normal, healthy, young, maybe.
I think
with a professional which exhausted, maybe.
I think this question comes up a lot, and I think it is important for us to be honest ourselves and with our patients. We as endocrinologists, if we think that a person has deficiency of some hormone, we check for the labs, we assess the hormones. If the hormones are low, we try to find out why and replace. If the hormones are normal, then we counsel the patients that the etiology of their symptoms lies elsewhere. So there are so many things which are ongoing in people's lives, from depression, social issues, financial issues. If testosterone is normal and measured appropriately, you can reassure them. And
Okay. Another just seen, this is from Dr. Wiam, just seen 21 years old with 0.4 testosterone and low LH and FSH, 0.5 and 1. And all other labs are normal. MRI, small pituitary only. How would you treat now and later?
So the first part, Dr. Ali, I missed that testosterone is normal?
Is low. Testosterone is low, very low. And low LH and FSH.
Okay, so the first thing would be whether we have excluded hyperprolactinemia and whether we have excluded also pituitary lesion. Looks like MRI was done and it was normal.
Normal, yeah. Pituitary, small pituitary, they report. He write to me.
Understood. And if all the other pituitary hormones are also normal, then I think depending on the clinical context, one has to figure out whether there is, and I do not know the testicular size, whether the testes had properly developed or not, whether this person is masculinized or not. I think I would approach the patient as a total. And if there are indications that this person has a genetic reason for central hypogonadism, to conduct such studies to make sure that the person doesn't have Kalman or its variant, or try to figure out what else might have happened in the patient's life that has resulted in this significantly profound central hypogonadism, maybe extreme weight loss, maybe the person is on any other medication. So tough to evaluate until you see the patient and know the whole context.
Thank you. There is the last question. Is there an association between testosterone treatment with long-standing untreated hypogonadism and prostatitis? So if you start testosterone, does that inflare prostatitis or something?
No, no such thing. Prostatitis are common spontaneously anyway, and subclinical prostatitis are even more common than clinical prostatitis, because many times when patients have increase in PSA who are not even on testosterone, and prostate evaluation is normal, urology friends of ours can sometimes prescribe 5 days of ciprofloxacin, which results in normalization of PSA. So, but testosterone related, there is no clear-cut evidence that it exacerbates prostatitis.
Okay. 1 minute only before we finish to the next session. So I would like to thank you, Professor Passaria. It was a great session. We enjoyed it. We learned a lot from it. And I hope we see you again in the future meetings. And thank you very much. With that, I conclude this session. And for the next to start according to circumstance. Thank you.
Yeah, I would say a pleasure was mine, and I want to thank the organizers again, and also to you, Dr. Al. Be well.
Thank you very much.
Bye-bye.
I appreciate it. Welcome, Professor Saud Al-Sifri and Professor Khalid Rassali. Thank you very much. Bye.
Assalamu alaikum wa rahmatullah. Good evening, everybody. I'm Saud Al-Sifri, an endocrinologist. I'm very happy really to welcome you on the 7th Gulf Endocrine Review course, which is really one of the features and one of the landmark events always conducted by the Gulf Association of Study of Endocrine and Diabetes. So I would like to welcome all participants. And again, you're going to hear a very interesting sessions where we talk about lipid disorders. Here we have invited one of those, one of the most prominent and distinguished professor, Khalid Rasadi, who's a director of the Medical Research Center at Sultan Qaboos University and a professor of biochemistry, College of Medicine and Health Science. And again, he's a consultant lipidologist at Sultan Qaboos University Hospital, where currently he is the president of Oman Society of Lipid and Atherosclerosis. And again, Professor Rasadi is a well-known, whether at Oman or again in the region of Gulf or internationally, for his distinguished work on lipid, where he had got his postgraduate fellowship from McGill University in Canada, that was followed by working in a hospital of Royal Victoria Hospitals at McGill University, where again he had been got and awarded the lipid research and clinical lipidology by the National Lipid Associations in the United States. And again, Professor Rasadi now is working as a professor at the Department of Biochemistry at the College of Medicine and Health Science in Sultan Qaboos University, where really he had been directing his medical research center at Qaboos Sultan University. And he's a founder member of the Oman Society for Lipid and Atherosclerosis, where currently he's the president of the society. Again, Professor Rasadi is led many research studied either nationally at Oman or regionally in the Gulf and Middle East region, where some of them are well known to most of us, which is the Gulf Familial Hypercholesterolemia Study, and again, the Oman FH Cascade Screening Study, and again, more of this. So I think Professor Rasadi does not need to be introduced, where we would leave for him the stage where he would talk about lipid disorders, and we are going to enjoy the session. So I would promise you that you will never regret that you've been here with Professor Rasadi. So I'll leave the stage for you, Professor Rasadi, and we are eager to hear from you things which is related to lipid disorder. So please, the floor is yours.
Thank you very much, Saud, for the kind welcome, and I'm really very happy also and glad to be part of this prestigious course, and hope that we can also share the experience. All right. So mainly what I will do, I will discuss cases in lipid disorders management. So I have around 4 cases, and I hope we'll have the time really to go through all of them. So this is case number 1. As you can see, this is a 55-year-old man with a long-standing history of type 2 diabetes. Also, he has a history of hypertension, dyslipidemia. And since this condition were diagnosed, he has been on dietary and also medical therapy. He's a non-smoker, but he have a high body mass index, which indicate obesity, as you can see, 32. And this is because of his lifestyle mood. Medication include 10 milligram of DABA and 2 grams of metformin, and also 80 milligram of valsartan. So this is his lab results on the existing treatment. So you can see very well his glycated hemoglobin A1C is not very well controlled for his risk profile. He has also raised creatinine around 132 micromole per liter, positive urine dipstick for protein. And if you see his lipid profile, his total cholesterol is 5.3. He has also high triglyceride, 3.5 millimole per liter, low HDL 0.9. And his LDL cholesterol, of course, we'll see according to the guidelines. It's again, it's not in the optimal for the risk of these patients, which is around 3 millimole per liter. And also in this patient, we'll learn about what is the importance of non-HDL cholesterol, especially in this type of patients, which is again also not optimal in this patient, 4.3. So the non-HDL basically is the total cholesterol minus HDL, and it gives you more information, but we'll speak about that definitely. So this is the first question for you. So what is the cardiovascular disease risk category of this patient? Again, I concentrated here on the American Association of Clinical Endocrinology and American College of Endocrinology 2020. So what do you think? Is it A, moderate risk, B, high risk, C, very high risk, or D, extreme risk? Okay, so there are, different answers and responses. So the majority say high risk, but I can see also some people say very high risk, and some also, between the moderate risk and extreme risk. So that's fine. So what we'll do, we will go through why you were maybe confused with what type of risk in this patient. So if we go to the American Association of Clinical Endocrinology, and that was published around 2020, so you can see very clearly that how we define patients with high risk. If they have more than 2 risk factors and 10 years risk score of around 10 to 20%. Also, if they are diabetes or chronic kidney disease with equal or more than 3 with no other risk factors. So definitely this patient can, like you said, can fulfill this criteria. But if you look here at also what is very, very high risk, mainly patients with diabetes with more than one risk factors. So this patient, you remember that he long-standing diabetes, he have hypertension, dyslipidemia, high creatinine. Also, he showed some albuminuria, proteinuria in urine. So he could basically goes more with very high risk than the high risk. How about extreme risk? So here, if you can see the extreme risk, mainly patients with already either a progressive atherosclerotic cardiovascular disease or patients with established clinical atherosclerotic cardiovascular disease, of course, plus diabetes or chronic. So this patient, we did not have any, evidence that he is either a progressive atherosclerotic cardiovascular disease or with established clinical atherosclerotic cardiovascular disease. So most likely, from these guidelines, these patients fit into what into the very high risk. But again, this is always these guidelines always is to guide you, okay? But really, you should know the patient more than anyone, and you should also learn about how also we can sometimes upgrade these patients. Sometimes patient could be upgraded from high risk into very high risk, or from very high risk into extreme risk by using what we call risk enhancer. Also looking at other guidelines. So here we had concentrated in the question maybe on the American Diabetes Association guidelines, but if you look at our consensus clinical recommendation for the management of plasma lipid disorder in the Middle East, which we published it in 2016, then we updated in 2021, and you can see it contain different experts from cardiologists and lipidologists, endocrinologists, and so on. So this is the beauty about this consensus. So you can see here in our guideline how we define the very high risk patients. Again, diabetes plus microvascular disease and organ damage like nephropathy, retinopathy, and neuropathy. These patients have some evidence of neuropathy, or chronic kidney disease, stage 3-4, or familial hypercholesteremia plus one or more risk factors, or Q risk score 10 to 20%. How about what we call extreme risk? You can see there diabetes, again, plus microvascular and organ damage, okay? So this patient, again, they could be, really classify again also into what we call extreme risk if they have established a clinical atherosclerotic cardiovascular disease. But again, this patient did not have that. So most likely, again, even according to our guidelines, he will still be at the very high risk. So how we can, like I told you, upgrade these patients into one category into another category by using this, what we call risk enhancer. So risk enhancer for example, diabetes is long duration of diabetes, more than 10 years for type 2 diabetes, or more than 20 years for type 1 diabetes. The presence of albuminuria, or albumin to creatinine ratio higher than the cutoff value, low estimated GFR below 60, the presence of retinopathy, neuropathy, or even peripheral artery disease, which is indicated here by the arterial brachial index below 0.9. So if we see this patient, they fit into, so he have long duration, although we didn't specify, and he has proteinuria already, and he have also high creatinine. So these patients also sometimes we can upgrade them into a higher risk, even if they don't have what we call atherosclerotic cardiovascular disease. So again, those who said extreme risk, it could be, but we need some evidence. And this evidence comes from here again, that doing some also radiological investigation, like, the calcium score. So calcium score, if it is more than 100, usually indicated a subclinical atherosclerotic cardiovascular disease, or a CT, a cardiac also in this patient. And if it show significant coronary artery stenosis, also it could indicate the presence of atherosclerotic cardiovascular disease in this patient. And this is what is really recommended in this patient, that you don't stop at one category and you have maybe to risk enhance, use this risk enhancer to evaluate this patient. Why? Because sometimes, the LDL cholesterol target depends on this different category. The other thing is using more aggressive treatment or combination therapy early in the stage of this patient to prevent, progressive, either prevent first event or prevent progression of atherosclerotic cardiovascular is very important in this patient. So always we have really to keep that into our mind, that using this risk enhancer and risk assessment is very important in this patient, especially if they not yet present with events, and we want to see if they are at risk for that. So this is again from the Middle East, and we will speak about what are the different target therapy for this patient according to the to their risk category. The other thing that also I want to bring into your attention, although we said always, patients with diabetes are already recognized as a high risk or very high risk, maybe not all type of diabetes behave the same. So really it depends on what are other risk factors, or how much control is their blood sugar. So you can see in this European Society of Cardiology publication in 2023 regarding prevention of cardiovascular disease in patients with diabetes, they had also subcategorized patients with diabetes. So low risk cardiovascular risk in patients with type 2 diabetes, again, not fulfilling the criteria for the very high risk, and their 10 years cardiovascular is below 5%. Although we said sometimes we don't really need to maybe calculate the risk in these patients with diabetes. If you look at moderate cardiovascular risk patient, again with type 2 not fulfilling the very high risk, or again 10 years cardiovascular risk between 5 to less than 10%, using this special score 2 diabetes. High risk cardiovascular disease, again patients with type 2 diabetes but not fulfilling the very high risk. Again, the 10 years is between 10 to less than 20% using the score diabetes. Very, very high risk. These are, again, patients with type 2 diabetes with established atherosclerotic cardiovascular disease, or if they have, a severe target organ damage. So although, so again, in this category, this is what they have added. So if patient is not having atherosclerotic cardiovascular disease, but he have target and organ, then he should be at the very high risk. And again, there are cutoff LDL cholesterol levels for these different risk score. As you can see, the very high risk, the LDL cholesterol should be below 1.4 or below 55 milligram per deciliter. In high risk, LDL cholesterol below 1.8 or below 70 milligram, and in moderate risk, LDL below 2. So here, again, we are talking about type 2 diabetes and how we should risk categorize these patients. Previously, we were believing that most of the type 2 diabetes should be between high risk, and then they can be categorized into very high risk or extreme risk according to whether they have more risk factors or and organ damage, or if they have this presence of atherosclerotic cardiovascular disease. But we can see now this differentiation. Why? Again, maybe because we need to know which type of diabetes we need to treat them more aggressively using these, novel therapy or target therapies, not only for lipid lowering, also for the new type diabetes treatment that showed also cardiovascular benefit, because some of those medication are relatively expensive, and you need sometimes to use this risk category to know which patient will benefit the most, will have the what we call cost benefit from adding this combination therapy even at the earlier stage in treating these patient. So let's go to question 2. So knowing that these patients, let's say now we decided that he's almost at the very high risk. So what do you think the therapeutic LDL goal for this patient? It should be A, below 2.6 millimole per liter, B, below 1.8 millimole per liter, C, below 1.4, or D, below 1 millimole per liter. Okay. So again, I see there is some consistency, compared to the first question. So most of you think that his LDL cholesterol should be below 1.4, and for those who said below 1.8. I think, again, using the clinical guidelines and also adding to that the clinical experience, both of them are true. And again, using risk enhancers in this patient could also help. So let's see. So we said that these patients most likely he fit into very high risk, okay, because he have diabetes with equal or more than risk factors. So if we look at the LDL cholesterol, it is below 70 or below 1.8 millimole per liter. But again, if you use, a risk enhancer in this patient, definitely you can, although, here in the extreme risk, most of the time they said, it should be either progressive atherosclerotic cardiovascular or established clinical atherosclerotic cardiovascular disease, or history of premature atherosclerotic cardiovascular disease in the family. Then he is extreme risk, and then LDL cholesterol should be pushed below 1.4 or below 55 milligram per deciliter. So I think both answers are fine. Again, use these guidelines as a guidance, but definitely you have to use also your clinical experience with these patients, using this risk enhancer or the assessment with these radiological. In our guidelines also, because we it's almost similar to what's shown, so very high risk. So again, it should be reduced by equal or more than 50% from baseline in this patient, And also he should, have this target below 70 milligram or below 1.8 millimole per liter. And if we look also at the new guidelines, again, this is very high risk. I mean, according to these new guidelines, the 2023, and this patient should be below 1.4. So again, for those who said that this patient should be in the very high risk, again, because of this different in guidelines. So no one will say you are not right. I mean, in saying whether these patients at at very high risk or extreme risk, and the difference in the how much you should reduce the LDL cholesterol. There's a small differences between these guidelines, how much maybe aggressive you should be with your patient. Again, this is you should use your common sense when you deal with these different patients according to their compliance, family history, and again of using those risk enhancer. Okay, so let's go to question 3. What will be the preferred type and dose of statin for this patient? Do you think atorvastatin 80 milligram, simvastatin 80 milligram, pitavastatin 4 milligram, or rosuvastatin 4 milligram? So we said we would like to reduce his LDL cholesterol at least by 50%, or let's say below 1.8 millimole per liter, which is around almost 74%, something like that. So which one you think? Okay, so again, I can see a division between atorvastatin 80 milligram, 29%, and rosuvastatin 40 milligram. So I think this is again excellent, answers, because atorvastatin 80 milligram is a high intensity statin, and also the rosuvastatin 40 milligram is the high intensity statin. Of course, pitavastatin 4 milligram also considered a high intensity, and simvastatin 80 milligram is considered high intensity. We don't use 80 milligram of the simvastatin because of the risk of increased risk of myalgia in these patients, and also rarely could happen rhabdomyolysis. So simvastatin 80 milligram is not very commonly used. Atorvastatin 80, rosuvastatin 40 milligram, but I mean, there is an increase now in the use of pitavastatin in this patient, and we will know maybe the answer for that. So if you see here again in this the European Society of Cardiology guidelines in 2023, again, they almost the first choice and the first line should be always statin, and and it should be high intensity statin, either rosuvastatin between 20 to 40 or atorvastatin 80 milligram. Again, these are patients are at very high risk, and you need also to reduce the LDL cholesterol by more than 50%, at least 74% in this patient. So, and we know that using statin will reduce cardiovascular and cerebral complication. It have also been shown it can reduce also mortality. Although there's an increase in the incidence of diabetes by 9%, but these are patients who are already diabetes, and maybe you could manage their diabetic control. So because the benefit of statin reducing cardiovascular disease complication is beyond the increase in the new incidence of diabetes in patients who are not diagnosed with diabetes, or even increase in the hemoglobin A1C in this patient. So the other, of course, treatment that can be used also in this patient, like ezetimibe and PCSK9, but this could be used also in combination therapy with this high-intensity statin. Or if the patient is statin intolerant, definitely then using, ezetimibe will not be enough, but the use of PCSK9 with and without ezetimibe maybe will be a good alternative in this patient. We will learn more about the use of the high dose EPA, equispent ethyl, from the REDUCE-IT trial, which also showed that it can reduce both the triglyceride and reduce cardiovascular disease. So in these patients, also it can be a good alternative, but again, it have to be used in combination with statin if this patient is not statin intolerant. Okay, so let's go to question 4 now. Which of the following statin was not associated with impaired diabetic control? So what do you think? Is it atorvastatin, rosuvastatin, C, simvastatin, or D, pitavastatin? Excellent, very good. It showed that you had read about it very well. So I highly concord with with the majority of the answer with the pitavastatin, and you can see very well from this publication in 2022 the impact of pitavastatin on new onset diabetes compared with the use of atorvastatin and rosuvastatin. So this was from almost a real world database, 10 different studies. So you can see very well from the overall, so compared pitavastatin to the use of atorvastatin or rosuvastatin in this patient, that pitavastatin have less incidence for new onset of diabetes in this patient, and you can see very well that it was significant less risk for developing diabetes. So this is why, I mean, in many centers now, they are really also moving to the prescription of pitavastatin, especially in those patients who can, have higher risk of developing diabetes, like those patients with obesity, metabolic syndrome, and so on. Or even if there's difficulty in controlling also the hemoglobin A1C in this patient, then pitavastatin will be a good option for this patient. Okay, I think this will be the last question from this case. Question 5: which of the following risk is likely to be developed in patients with very severe triglyceride level? Do you think is it pancreatitis, kidney disease, peripheral artery disease, or cardiovascular disease? Excellent. So pancreatitis, I totally concur with, again, and agree with your answer. So this is the most likely risk and complication, especially in patients with very severe high triglyceride. Usually if it is more than 10 millimole per liter, around more than 1,000 milligram per deciliter, then the risk of triglyceride is high. Although, of course, definitely that high triglyceride was also associated with the development of cardiovascular disease, especially in patients, again, with diabetes. So this is where we have also to concentrate also on managing triglyceride in these patients after, of course, controlling the LDL cholesterol and non-HDL cholesterol. So you can see here from from these publications that the incidence of acute pancreatitis by the level of triglyceride. So if the level of triglyceride is almost more than 10 millimole, then you can see very well that the risk of acute pancreatitis is higher. Here in the past 12 months, and one incidence of acute pancreatitis. So and then more than two equal or more than two acute pancreatitis in the past 12 months. Again, it's raised significantly when the when the triglyceride goes above 10, and of course above that. So in this patient, when the triglyceride is extremely high, then we need really to focus not only putting them on statin, because statin, of course, the higher the dose of statin will help in reducing the triglyceride, but maybe it will not be enough to reduce the risk of pancreatitis in these patients. So always it will be good to add other treatment that concentrate on reducing triglyceride, like the fibrate, and we prefer, of course, to add fenofibrate, because it's the combination of fenofibrate and statin has less risk of developing myalgia and rhabdomyolysis in this patient. Omega-3, especially with the EPA, because it have shown to reduce cardiovascular disease, but also you can use the EPA DHA, especially with the high triglyceride, will be also another good option. And always don't forget, in these patients with severe triglyceride, the diet with low simple carbohydrate and low saturated diet restriction is very helpful in reducing the triglyceride in this patient. So I think we had finished from discussing the case 1, and now we can maybe move to case 2. So this is a 45-year-old woman with a long-standing history of type 2 diabetes, similar to the previous case. This patient, she was admitted to the hospital with chest pain, and she was diagnosed with ST elevation myocardial infarction, and she underwent cardiac catheterization and found to have 70% occlusion of her right coronary artery and 60% of the left circumference occlusion, and she underwent a percutaneous intervention to both the RCA and LCX. This is the lab result. The hemoglobin A1C better than the previous case. It showed better control, around 7%. The total cholesterol is 5.3. The triglyceride is still high, 2.8 millimole per liter. The HDL is low in this patient, and always this the level between the HDL and triglyceride. So always when the triglyceride is high, the HDL decrease, and this is again because of the cholesterol ester transfer protein, where they transfer cholesterol to the ApoB containing particle, and triglyceride from this ApoB containing particle to the HDL becomes larger, and then it can be exposed to hepatic lipase, where it degraded, make it small, and can be excreted by the kidney. So this is why always the HDL, you see it low in these patients with high triglyceride, and when you correct the triglyceride, then the HDL improve in this patient. So the LDL cholesterol, again, 3.5, and we'll see that this is not the optimal for the risk category of this patient. Then HDL cholesterol, again, high, 4.4. And This is another markers, the lipoprotein A. One of the new emerging marker for increasing cardiovascular disease. And usually if it is above 100, it indicates high risk in this patient. So this is another risk enhancer that can be also used in this patient. So let's go to questions now. So which is the cardiovascular risk category of this patient according to the, now I had just give you another guideline just to show you how the difference between the guidelines. So this is the European Society of Cardiology 2019 guideline. So what do you think? These patients mild risk, moderate risk, high risk, or very high risk? Excellent. So most of you answered really these patients is very high risk. Maybe I will not agree with those who answered high risk, and we will show you why. So this is the European Society of Cardiology, the 2019 guidelines. Remember, this is the oldest. This is the European Atherosclerosis Society, European Society Cardiology guidelines, and not the recent European Society Cardiology guidelines. So if we look at the definition of very high risk, in these guidelines, they don't use the extreme risk, but they use the very high risk. So who are the patients with very high risk? Again, it should be patients with documented atherosclerotic cardiovascular disease, either with clinical, like this patient, he presented with myocardial infarction, or also with imaging. And this patient is actually in this category. Diabetes with target organ damage. Again, this is patients with diabetes, and do we know that she have more than risk factors? We did not see that in the history, but I mean, definitely if they had already established atherosclerotic, then they are at very high risk. What we see also in this category, and we will speak about it later on, that patients also, they put familial hypercholesteremia with atherosclerotic cardiovascular disease, or familial hypercholesteremia with no atherosclerotic cardiovascular disease, but with another major risk factors. So FH with diabetes will also be put in this category of very high risk patient. So we can see very well that this patient really fit into the very high risk. How about high risk? So now here you don't see any cardiovascular disease, established cardiovascular disease, or even subclinical atherosclerotic cardiovascular disease, but you see that these are patients with either familial hypercholesteremia, or patients with diabetes without target organ damage, and so on. So unlikely this patient to be at high risk, most likely to be at the very high risk. If we look also at the American Association of Clinical Endocrinology, and these patients mostly will not be only at very high risk, but again will be at extreme risk. And you can see that their LDL cholesterol here will be changed from below 70, which is below 1.8, to below 55, which is around below 1.4 millimole per liter in this patient. So again, this patient most likely fit into the extreme risk in this case. How about our guidelines? Again, similar. So atherosclerotic cardiovascular disease, we had plus, of course, established clinical atherosclerotic cardiovascular, diabetes with established atherosclerotic cardiovascular disease should be at extreme risk. So our guidelines also indicate that this patient could be also labeled as extreme risk if you are using, of course, these guidelines. How about the 2023? Again, these are patients with established atherosclerotic cardiovascular disease and having diabetes, so will most likely be categorized as a very high risk. So you have seen that why we had said most likely these patients are at very high risk. Okay. How about question 2? What is the therapeutic LDL goal for these patients? So let's say if these patients are, at either extreme risk or at very high risk. So what do you think will be the LDL cholesterol target for this patient? Okay, excellent. You can see very well that most of you had answered C, and I think this is the most correct answer, because you can see at the 2019 European guidelines, actually, the very high risk patient, who are these very high risk patient, again, patients with atherosclerotic cardiovascular disease, either clinical or imaging, high score, more than 10%, FH with atherosclerotic cardiovascular disease, or FH with another major risk factors like diabetes, severe chronic kidney disease, diabetes with target and organ damage. So these are patients with very high risk, and you can see very well their LDL cholesterol should be reduced more than 50% from baseline, and also the target should be below 1.4 millimole per liter or below 55 milligram per deciliter. Those patients also can go from very high risk into extreme risk, although it was not really indicated in their guidelines, but they had spelled it with the guidelines if they have another event or progressive event. So if they have another event, then their LDL cholesterol should be dropped from even less than 1.4, which is should be even below that. So this is only in indication where the LDL cholesterol should be reduced even more aggressively in these patient, which is below 1. Okay, if you look at the American Diabetes Association, again, we said these are most likely at extreme risk, and for extreme risk, LDL cholesterol again below 1.4 or LDL cholesterol below 55 milligram per deciliter. In our guidelines, also extreme risk reduced by equal or more than 50%, and their LDL cholesterol below 55 milligram per deciliter, which is below 1.4 millimole per liter in this patient. How about the latest European Society of Cardiology? Again, very high risk, and LDL cholesterol should be below 1.4. So you saw very well that most of these guidelines have really agreed that these LDL cholesterol should be reduced below 1.4, regardless whether you label them as very high risk or extreme risk. This LDL cholesterol should be below 1.4 millimole per liter. Okay. Question 3. what is the therapeutic non-HDL cholesterol for this patient? You have seen from those guidelines, I show you some hint. So what do you think? If we say the LDL cholesterol should be below 1.4, what do you think should be the non-HDL? Is it below 3.4, below 2.6, below 2.2, or below 1.8? Okay, excellent. So I think most of you had answered below 2.2, okay, because we know that the difference in non-HDL is almost 0.8 millimole above the LDL cholesterol target in this patient. So so what is non-HDL? Non-HDL is the contain most of the atherosclerotic what you call particles, or ApoB containing particles. And so studies show that those patients who are reaching the LDL cholesterol target but still not at their non-HDL target, they have like 32% risk of having either the primary event or even a secondary recurrent event. So and you should keep that into your mind. So controlling the LDL cholesterol, especially in patients with diabetes with or without atherosclerotic cardiovascular disease, is not enough. You should always look at their also non-HDL, because it means that the ApoB containing particle is still high in this patient, and they predisposed to more risk. And usually the non-HDL is high, especially in patients with the highest triglyceride, and this we can see it definitely in patients with obesity, metabolic syndrome, in diabetes. This is what we call it, the atherogenic lipid profile. You can see in these patients also low HDL cholesterol because of the high TG, and the small dense LDL particles, again because of the activity of the cholesterol ester transfer protein. So these particles become more dense with LDL cholesterol, and they are small, so they can penetrate easily the blood vessels, causing more atherosclerosis in these patients. How to calculate the non-HDL? So it is the total cholesterol minus the HDL. So it contains all the atherogenic containing particles, the ApoB containing particles, whether we are talking about LDL cholesterol, intermediate density cholesterol, or very low density lipoprotein, or even the chylomicron remnant. So it's better than just concentrating on the LDL cholesterol in these patients with diabetes. It contains all these atherogenic lipoproteins, so it is really very, very important. So if we look at these patients again, what is the non-HDL target in this patient? Sorry, I say 2.2. So maybe, sorry, that was my mistake. So it should be really below 80 in these patients, because we said the LDL cholesterol should be reduced below 1.4. So non-HDL should be also reduced below 80, which is around I think it's around 1.8 millimole per liter. Okay. And if we look also at our guidelines, okay, so the non-HDL cholesterol should be reduced below the LDL cholesterol below 1.4, so the non-HDL cholesterol should be reduced below 85. It's below 2.2. So correctly, yeah, it's below 2.2 actually. Okay, so let's go to question 4. So the correct answer is still 2.2. Okay, question 4. Which of the following combination lipid lowering treatment should be started before the discharge of these patients? So these patients presented with myocardial infarction, and so which is the most appropriate lipid lowering therapy, knowing that LDL cholesterol should be reduced to below 1.4 millimole from the baseline. So do you think high dose statin alone, PCSK9 inhibitor alone, high dose statin with ezetimibe, or high dose statin with PCSK9 inhibitor? So what do you think? Okay, so high dose statin with ezetimibe, 73%. And the other say high dose statin with PCSK9 monoclonal inhibitor. Okay, so both are correct, but we should look at so before going to the right answer, I think most of us now looking at what we call early combination therapy in these patients who are at very high risk or extreme risk. So at discharge, we should really put these patients on more aggressive therapy. So this is from one of the study where they looked at the observed LDL cholesterol target attainment in patients who was admitted with myocardial infarction and put on the different treatments, and then post follow-up discharge, 6 to 10 weeks. So we can see that there is, their LDL cholesterol, there's a huge variation at admission, and post-therapy, very few had reached the LDL cholesterol below 1.4 millimole. Again, if you look at why, because most of these patients were either on high-intensity statin alone or a high-intensity statin with ezetimibe. Although that was really better from the baseline. But if we take a simulated model that if we increase more on the combination therapy, that we give these patients high-intensity statin, ezetimibe, and PCSK9, then the reachment of the LDL cholesterol below 1.4, the percentage will be even higher. So this is why it is important always to know what is the baseline of LDL cholesterol in this patient when they presented, and how much you want to reduce it. So it will give you a hint at which treatment should be on. So if you see, again, this is a similar from a different study that again showing the same results. Maybe I don't really need to repeat it. Sorry, I should go back. How should I go back? Yeah, maybe I forgot to put a slide, but maybe we will talk definitely about it. So it really depends on the baseline of the LDL cholesterol and how much percentage reduction of LDL cholesterol you want it to be in this patient. But definitely there will be another case, and maybe it will make it more easy. So most likely these patients, if we require around 64% reduction, so maybe high intensity statin with ezetimibe will be definitely enough for this patient. And I think this is most of you had answered that. Okay, so let's go to question 5. I think this is the last question in this part. Which of the following lipid-lowering therapy you will consider to manage the high triglyceride in these patients? Is it fenofibrate, pimafibrate, gemfibrozil, or omega-3 in this case? What do you think? Okay. So most of you say fenofibrate, 77%, and the others also, the higher response was for omega-3. So I think, again, both are correct to say, and definitely not the gemfibrozil, because using it with, with high intensity statin will increase the risk again of more severe myalgia or even rarely rhabdomyolysis. So it's not always good to use it, maybe as a single therapy, but not. Pimafibrate also is a good therapy, but so let's look at the studies where it had shown that where's the benefit in these patients. So like I told you, most of the time we should concentrate in the LDL cholesterol as a primary target of therapy. And secondly, we should look at the non-HDL cholesterol. And then if these patients have a high triglyceride, we know that from the subgroup trials, especially with the fibrate, that in those patients with high triglyceride, obesity, and also low HDL cholesterol, they benefited from the additional of fibrate on the top of statin in these patients. So this is why most of the guidelines really recommend that the first choice always should be statin in this patient. But if you control the LDL cholesterol and the triglyceride is still high, then you can add the omega-3 fatty acid, and especially with the EPA, because we have more evidence with the reduced study. So it's a class 2A. Fibrate also can be added, in patients with primary prevention, if the LDL cholesterol at goal, but still triglyceride is high, and also in patients with secondary prevention or those with high risk. Again, if the LDL cholesterol at goal, but the triglyceride is still high, then you can also add fenofibrate. So those of you who answered the omega-3, especially the EPA is correct, and also fenofibrate is correct. And we should also know that there are some studies showing that fenofibrate could also help in managing some of those microvascular disease, which is really very common in these patients with diabetes. So maybe this is an additional, although it's again not yet as approved by most of the guidelines, but I mean it could be also benefit in this patient. The 2020 also, the American Association of Clinical Chemistry, also you see in those patients again with high triglyceride, they put also a target for the triglyceride, which should be below 1.7, which is around below 150 milligram per deciliter in these patients. Again, statin should always be the first therapy, moderate to high intensity, and adding again the EPA at 2 gram BID should be considered if the triglyceride is not controlled in these patients. But you can see also in these guidelines, You can also consider the fibrate. Niacin, we don't use it very common now because of the, study did not show, cardiovascular benefit, and also some serious side effect from it.
Prof. Khalid, we've got 10 minutes.
10
it's
minutes.
very interesting and we are enjoying it, but because of
thank
the
you very
time
much.
limit, so we've got 10
Okay.
minutes, please.
Okay, so I think I will go maybe more faster with this. So in case 3, this is a 37-year-old gentleman was referred to the lipid clinic with history of dyslipidemia, no history of diabetes, no hypertension, no ischemic heart disease, and family history of first degree for coronary artery disease. You can see the lab results: normal triglyceride, very high total cholesterol, and it's mainly to do with LDL cholesterol 7, HDL is low, hemoglobin A1C is very, he's not diabetic, and you can see that, and no other laboratory or biochemical abnormalities. So what do you think? What is the cardiovascular risk category, again, according to the European Society of Cardiology 2019 in this patient? Mild risk, moderate risk, high risk, or very high risk? Okay, so 36%. I see there's, a variation in the answers. Again, maybe some of you are not familiar maybe with the familial hypercholesteremia risk category, but I can show it to you very well. So this patient is only purely familial hypercholesteremia with no atherosclerotic cardiovascular disease and no other major risk factors. So we know what's familial hypercholesteremia. It's a genetic disorders, and it's mainly an autosomal dominant disorder. Accumulation of LDL cholesterol in the blood risk these patients for high coronary artery disease. Diagnosis, it can be done by clinically by using these different criteria, the Dutch criteria, the Simon Broom. We prefer the Dutch criteria, especially we utilize it in the familial hypercholesteremia registry in the Gulf region. And we know that these patients are very, very high risk for atherosclerotic cardiovascular disease, especially the homozygous, the severe one. And if they are not diagnosed early and managed early, for homozygous, they can develop heart disease by before the age of 20, and for the heterozygous before the age of 40. This is why screening and management is very important. And we know that if they are an LDL receptor positive, mean that the risk for cardiovascular disease is higher than those with LDL receptor negative, or you cannot find the actual mutation in this patient. So cardiovascular disease for FH, very high risk only if FH with atherosclerotic cardiovascular disease, or FH with another major risk factor. So, and we saw that this patient did not have any other major risk factors. So most likely he will be at the category of high risk. And this is again goes with our consensus. So FH with no other risk factor. So he is at high risk. What do you think the LDL cholesterol for this patient? Below 2.6, below 1.8, below 1.4, below 1, if you think that this is, a high risk. Okay, excellent. So below 1.8 millimole, the majority of you had answered that. So again, if we go to high risk, again, it's from the European, say very clearly here, the LDL cholesterol should be below 1.8 millimole per liter. But if there's FH with another major risk, so this is very high risk, and the LDL cholesterol should be below 1.4. Again, similar to our criteria, we should reduce the LDL cholesterol below 1.8. Okay, next question. Which of the following lipid treatment will help reaching the LDL goal in this patient? So his LDL cholesterol was around 7. Again, excellent. So high dose statin with PCSK9 inhibitor. Yeah, this is the right answer. Why? Because we see very well. I mean, this is the expected effect of various combination lipid lowering therapy on LDL level. So if we use high intensity plus ezetimibe, we'll get 65%. So this patient will still not be at target below 1.8. But if we use high intensity statin plus PCSK9 inhibitor, then it will be 75%. So this is the right answer. So I think you should use this expected proportional LDL to guide you for how intensive you should be in these patients. So high intensity statin will not be enough for these patients. You should always go for combination therapy from the beginning, because you know what's the risk of this patient. This is why most of the guidelines, including the European guidelines, will say that in patients with very high risk, you should look at the combination therapy from the beginning, especially if they have atherosclerotic cardiovascular disease. Question 4, what is the prevalence of familial hypercholesterolemia in the Arabian Gulf region? What do you think? Okay. So the majority, split between C and D. So let me show you. So this is the Gulf familial hypercholesterolemia study, and the FH prevalence was again higher than what we see in the Western. So it was 1 in 112. So this is again because of genetic, and maybe the severe form is more common because of the consanguinity marriage in this patient. This is the last question from this case. Which of the following lipid treatment is not very effective in patients with severe, the homozygous form? What do you think? Excellent. Very good. So yeah. So lomitibide, evinacumab, LDL pheresis are approved really for patients with severe familial hypercholesterolemia. Pompidic acid is good for statin intolerance and patients with atherosclerotic, but it's not very effective in these patients. Doctor, I think we can stop here. Case 4 is about statin intolerance, so maybe we can discuss it during maybe question and answers if you want.
Excellent. Thank you very much. Thank you. To tell you the truth, really, I enjoyed it, and you took us through the journey of hyperlipidemia and how to manage different forms of cholesterol abnormalities. I think we've got many questions, so maybe that comes in one of your cases. Prof. Khalid, you were talking about the last case, which is going to be discussing the issue of statin intolerance. I think there was a question which was related in this. I'll just take it that question. So in both we are going to answer that. And this comes from our colleague Khadija. She's asking how to treat a patient with hyperlipidemia, high LDL, and intolerance of statin, so high CPK and myalgia. So I think maybe comes in that way. Please.
Thank you very much. Really, this is an excellent question. So always we have really to confirm the statin intolerance. I think by the challenge and re-challenge and changing between the different type of statin and also the different doses of statin. So definitely, if that does not work, we know that adding ezetimibe as a single will not be enough, especially in these patients with severe LDL cholesterol patient. So I think PCSK9 injection will be the best benefit for this patient. The pompidic acid also has been shown also in combination with with ezetimibe in cases or in cases of statin intolerance will be another also good option for this patient.
Excellent. And now always we've been asked this question, so it's good to comment on this. How we would label a patient that he's a statin intolerant? Is it that he could not tolerate, or is there like something where we would define them?
Yeah. I think that's also an excellent question, and it's really very difficult to how to define it. And looking at the prevalence of statin intolerance, it can vary from 9 to 20%. Again, emphasizing that the difference between the definitions and patient response as well. So I think the best way is really to individualize the type of patient. So changing again the type of statin, changing the dose, and if they continue to behave similarly, then this is definitely a statin intolerance. So but using the CK, sometimes it's not good. I mean, not all the patients will have a high CK despite they have a significant myalgia. So you should not really only confirm it by biochemically, but you should also listen to that patient and maybe doing this maneuver.
Excellent. Again, here, this question has been asked in two different ways, but it is the same. So our colleague Leila and Raed, they were asking, in a healthy person without diabetes, without any risk, what should be the LDL level target? And in the same way, is there any use or is there any place for using low density statin, or what they meant maybe low intensity statin?
Okay, so if this patient, I mean, depend on again if this whether low risk or moderate risk, and according to the different risk score. Although again, we were even in our latest consensus, we were debating which is the best risk score that we should use. Although these are mainly taken from the Western world, and we should have our own risk score. But we said with the Q risk, because it contains some ethnicity, so maybe that was the best. So again, I mean, if this patient at low or moderate risk, I think there may be no rush to use lipid lowering. And maybe dietary or lifestyle intensification will be helpful. If still they continue to have a high LDL cholesterol in a repeated or in a follow-up, maybe also the other good thing to use this risk enhancer that we have spoken about, like CT calcium score, LPA, for example, and maybe other maneuver, maybe to upgrade these patients. So maybe the prescription of lipid lowering will be justifiable in these cases. So always discussing with the patient the different option will be the best for commencing treatment in these patients.
Excellent. So is there still a place for what they call it low intensity statins? Because we are seeing many of our patients, they are using 10 milligram of
I think there is no place again for the low intensity statins now, because we did not have other options of statin. This is why the high intensity statin was always indicated. But now, with the presence of these different modalities, I think people even with moderate intensity statin and in combination with other therapy which have a cardiovascular benefit should be also fine.
Excellent. And now another question from colleagues that now with the pre-diabetes, where HbA1c is around 6, should we deal with them as diabetic patients, or they are still not? Or where should we put them as a risk?
Again, this is an excellent question, and it's a really very very challenging also. Again, for me personally, I will not maybe rush, because we know that pre-diabetes to do again with this lifestyle. So maybe concentrating again on on lifestyle intervention. But again, if they continue to behave the same, and also using other risk enhancer, then maybe this would be justifiable to put them on lipid lowering. But always, and this is what I say to my colleague, don't rush to use lipid lowering unless these patients are only at extreme or at very or high risk, and it is documented. At low, moderate risk, we try always really to go with more evidence.
Excellent. And now again from other colleagues, they are asking about hypertriglyceridemia. So in patients who has got a very high triglyceride, more than 500 milligram per deciliter, for how long should we keep patients on fibrate? So this is again another question.
Yeah, and this is also a very good question. I think I mean, although fibrate in general, they did not have an evidence when we look at the total cohort, but in only very specific patients, especially patients with diabetes. So I think if in diabetic patient, maybe I think it will be a good option to continue fenofibrate with statins, especially if they don't have any major side effects. But maybe in others who doesn't have diabetes or other metabolic syndrome, so maybe only treating the underlying cause will be better.
Excellent. Now another question seems to be a bit, if calcium score is 0 and patient is 45 years of age, no diabetes, the LDL is around 200 milligram, would you treat for primary prevention?
Yeah, and this is also another excellent question. This is what we have. So this is what we have seen when we, categorize patients with diabetes. I think similar thing can be also applied to familial hypercholesterolemia. So familial hypercholesterolemia, although it is a genetic disorder, not all familial hypercholesterolemia behave the same. We see, for example, a 60-year-old man or woman with familial hypercholesterolemia, and you do CT calcium score or CT cardiac, and it's clean. So so whether it depends on really the type of mutation, how high the LDL cholesterol in this patient, the presence maybe of other major risk factors. So maybe that will be the good thing also to look whether to treat, to put them on statin, moderate intensity. But will they require addition of ezetimibe, PCSK9, or other, intensive therapy? Maybe not. Okay, because again, I will put those combination therapy if there is another major risk factor. But starting them on statin, knowing that these patients are really at a minimum of high risk, will be worth it.
Okay. Excellent. Now, again, in FH, is the target LDL by default is less than 1.4 in all patients?
I think maybe not. Maybe those with, again, either atherosclerotic cardiovascular disease or more than one risk factor, especially FH with diabetes, because this is like, but FH with no other risk factors, I think should be below 1.8 should be sufficient. And this is why we said maybe statin should be enough for this patient and no need to add ezetimibe or other kind of therapy.
Okay. Now, other colleague, Dr. Yassin, is asking for Q-risk 3 calculator. is now recommended over the Q-risk-2 calculators. Do you agree on this?
Q-risk-2 for which patient, like the specific one, the diabetes or the general? I think again, I mean, even in our consensus, although we said we go with the Q-risk score, but we leave it open, to the physician or whoever taking care of the patient. So you can definitely use whatever risk score you want, but you have always to be careful. Interpreting sometimes this risk score maybe will give you maybe a false result. So use always your clinical impression. Again, discussing it with patient using other risk enhancer. So that will be also a good addition.
Okay. So our colleague Yassine is just following on that. For diabetic patients in the UK, they are using Q-risk-3. So thank you very much, Yassine. Okay. So here, this is an interesting question. Can we say that the patient has FH if only LDL is more than 190 without genetic testing? Do we need to do genetic testing for any suspected case of FH?
The genetic testing will be, a good confirmative test, but if it is not available, then LDL cholesterol by itself is not enough. I think there are other criteria like family history, first degree family history with high cholesterol or premature cardiovascular disease, presence of xanthomas and thalassemas and so on, and excluding, of course, secondary causes as well.
Okay, excellent. So here, this is another, and maybe this is the last one. I might say it in another format. Can we recommend pitavastatin as a high-intensity statins?
Yeah, pitavastatin at 4 milligram. I think it's considered as a high-intensity statin.
Statins, excellent. Yeah. Again, now we are at the end of the time. So really, I would congratulate you for being here for almost 2 hours talking. I think you need now to take your coffee, water, and many other things. Really, we have enjoyed it. It was an excellent session. I enjoyed it totally, and I think even colleagues from the question that we have received. So I would like to take this opportunity. Thank you, Prof. Khalid Radasi, and this was an excellent one.
Assalamu alaikum. Good evening and welcome to this session of the 7th GAID Endocrine and Diabetes Board Review. My name is Bashar Effendi and I am a member of the Board of Directors in GAID. It's my great pleasure to present Professor Thomas Dunn, who is the Director of the Department of Pediatrics, Endocrinology, Diabetology, and Clinical Research at the Deaf-Bold Hospital of Children and Adolescents at the Hanover Medical School in Germany. Prof. Dunn is an expert in type 1 diabetes. He is the past president of the ESPAD, the German Diabetes Association, and also the German Diabetes Aid. We are really privileged to have Professor Dunn review type 1 diabetes related topics. Prof. Dunn, please share your presentation and the mic is yours.
Okay, thank you very much for your kind words of introduction. And it's a big pleasure for me to be talking to you, although it is virtual. I've been to your beautiful countries for some times, and I've enjoyed it very, very much, and particularly the exchange with my colleagues. The topic tonight is type 1 diabetes, and I'm a pediatric diabetologist, so I will see everything a little bit from a pediatric point of view. But of course, we also treat adults in our center, so it's not only pediatrics. But to start things off here, I introduce case number 1, Abdul, a 7-year-old boy who is presented to the family doctor because he started wetting the bed at night. Again, something that hasn't happened for quite some time, so enuresis nocturna. When the family doctor speaks with the parents, he understands that Abdul has recently started a primary school education and has actually complained of feeling much more tired than usual. The mother thought, well, this is probably due to him starting school education, which could be quite tiresome. He actually lost some weight in the past weeks, but his body mass index was 17 kilograms per BMI is still pretty normal. And but the mother says, yes, he is actually drinking quite a lot of soft drinks. The family doctor did some tests immediately. He looked for the urinary status and found urinary glucose positive. So this is why he actually then also measured urinary ketones, which were positive. The glucose was 250 milligrams per deciliter, and his glycemic HbA1c was also high. Now, let's go directly to the next question. And here you have now the issues which are the typical signs for type 1 diabetes. Would this be a normal A1C, arguably below 6.0%? Would it be a random blood glucose below 200 milligrams per deciliter? Would it be the clinical signs of polyuria, polydipsia, and weight loss? Is it related to an unhealthy diet? And is there any relationship to a family history of enuresis nocturna? Okay, so this was more or less kind of a training, and 94% of you have actually, of course, said it's polyuria, polydipsia, and weight loss. The glucose, the random glucose, of course, should be more than 200 milligrams per deciliter. The A1C usually is elevated, but you have to be careful. A normal HbA1c doesn't necessarily make for sure that this is not a type 1 diabetes, but we'll come to this later. The diet, parents always think the diet plays a role, but actually the diet, as far as we know, doesn't play any role. And yes, that the bedwetting happening is simply because there is glucose in the urine and the child is unable to hold the urine, and this is why this happens at night. Now to move on, I now have a little bit of a problem. So this is the right answer here. Just to give you a little of a background, we have to understand, and we'll come to this later, that type 1 diabetes is a progressive autoimmune condition. It is the most frequent metabolic disease in childhood. There are the highest region of the world is Europe, but I'll show you in a moment. For example, in Saudi Arabia, there are also 30,000 children below age 19 living with type 1 diabetes. As a sign of the autoimmune disease, we can detect islet cell antibodies. And very importantly, these antibodies appear before symptoms appear. And because we have followed up those antibodies, we know that once there are 2 or more antibodies, there's 100% chance, we don't know exactly when this is going to happen, but that their type 1 diabetes, the insulin-dependent type 1 diabetes, comes into 100%. So nowadays we speak of a diagnosis of type 1 diabetes also without those symptoms that I've described to you earlier, when there are multiple antibodies detected. Now, of course, the question that the parents immediately answer is always, what happened? Why is this happening? And we have to understand that it's a multifactorial disease. a strong genetic component, but in 9 out of 10 cases, there is nobody else in the family who has type 1 diabetes. And we're still looking really to decipher this. There are probably many different reasons, many different influencing factors that are leading to type 1 diabetes, environmental triggers, viral infections, and this interplay is still not well understood. But what is understood is that the incidence of type 1 diabetes is increasing more or less everywhere. So it is certainly something of concern. Here you see the numbers for Saudi Arabia. It's certainly one of the things where you don't want to be on the first place of the column, but you can see that Saudi Arabia has really a big disease burden also with type 1 diabetes, so it's very relevant that this is part of this review course. Now, for adults, for children, mostly it is relatively easy and there are clinical signs because it's a very rapid progressing disease in childhood. In adults, it's a more slowly progressing disease. So as you also have then quite a lot of people with type 2 diabetes. Type 2 diabetes is very rare in childhood before age 12. So this is relatively more easy to detect. But of course, in adults, first of all, of course, age plays a big role, whether you consider type 2 diabetes or not, below or above 35 years. You always have to consider monogenic diabetes as one of the causes. You might consider testing C-peptide if you're not quite sure, but very important are the islet autoantibodies. This is kind of the first stage that you should do to either look into the type 2 diabetes as a possible cause or monogenic diabetes, because both of these are usually without the autoantibodies. Okay, so we would move on to the next case. In this case, again, a youth, in this case, a 14-year-old girl. She has been just diagnosed with type 1 diabetes by her family physician with these typical signs, and now is referred to a diabetes center as the family physician doesn't have experience with starting insulin therapy, and he doesn't have a multidisciplinary team, so that's a very good idea. But now the question is, of course, what to do. So when starting her insulin treatment with multiple daily injections, what are the therapeutic principles that should be considered? Is it that the insulin sensitivity is highest in the morning? Is it that the relative dose of basal insulin should be higher or more than the total prandial insulin over the day? Should we have the correction dose, one for the whole day or not? Should we relate the prandial insulin to the carbohydrate content of the meal? Or should the insulin dose be increased during physical exercise? So those are many different issues. Let's see what you think. Wow, experienced pediatric diabetologist in this group. The problem with the insulin sensitivity, it's actually the lowest in the morning. You're quite correct. It's sometimes a little bit misunderstanding because the insulin dose, the relative insulin dose in the morning is actually the highest, the insulin need, the relative insulin need. But this means that the insulin sensitivity is low at the morning. The dose of basal insulin, most of you had this right. We want to have less basal insulin and then prandial insulin. I'll come to that in a moment. Correction dose, we have circadian variation of insulin sensitivity. So this also goes for the correction dose. And yes, we believe that it is important, even with the most advanced types of therapy, as far as we know, the prandial insulin dose needs to be related to the carbohydrate content of the meal. Of course, this is very difficult to learn, difficult to teach, but if you want to reach the glycemic goals, it's what you need to do. And yes, we know that carbohydrates increase your insulin need and glucose dose. And on the other hand, that exercise is actually making you more insulin sensitive. This is why the insulin dose should be decreased during physical exercise. So here is where our correct answer is. The prandial dose should be related to the carbohydrate content. So here is the background, basically. In adolescence, you have the highest relative total insulin dose. Adults have less than in pediatric diabetes, and about 30 to 40% of the total daily dose should be basal insulin. We have to understand that the source of glucose in your blood comes from two sources. It's, of course, the exogenous glucose through your meal. But of course, there is, on the other hand, the endogenous glucose production in the liver. And the endogenous glucose is approximately 30% of the total glucose that is in your body. And this explains why the basal insulin is around 30 to 40% of the total daily dose, and the rest is the endogenous glucose. Now, as I said before, there is the basal insulin requirement, and just the same, of course, goes for the prandial insulin requirement. We have a circadian variation of the insulin sensitivity. It's high in the morning, low insulin sensitivity. We need lots of insulin for in the breakfast, because also the cortisol levels are high and it's kind of stress getting up in the morning. So that's why the insulin is not working so well. It is low at noon, so you have to be very careful at noon of dosing the insulin, high insulin sensitivity there. In the afternoon, again, it's rather low. And again, in the evening before going to sleep, we have a high insulin sensitivity again. We have to understand this is, of course, varying, that sick days, menstrual periods, stress is increasing your insulin need, and that obviously the insulin sensitivity is higher in exercise, and stress can actually be doing both. Now, I don't want to go into carbohydrate counting. I really want to refer to the guidelines here. There are several rules which you can do. Probably the most relevant ones are to calculate the insulin sensitivity with the 1,800 rule for those using milligrams per deciliter, or the 100 rule for those using millimoles. So I just want to refer to those that you can actually use them if you're not familiar with them. And the same goes for the insulin to carb ratio, obviously. So both the correction dose, which is the insulin sensitivity factor, or the insulin to carb ratio, has to follow this circadian variation. We move on now to James. James is an 80-year-old boy, again, has been just been diagnosed with type 1 diabetes. He is now getting this multidisciplinary treatment. It's educator helps the family. Of course, there's a doctor, psychologist, dietitian. Again, something that makes it clear that he has type 1 diabetes. He has the positive antibodies, GAID, IA2, and insulin autoantibodies. The question that we are posed now, what is really part of this comprehensive approach to help him to make diabetes work in his daily life? Does he need is there a one-size-fits-all education? Do you want to give him premixed insulin, as a child should at this age? You can first start with a simple therapy and then later on change to a more complicated one, trying to save those difficult injections, or a complicated pump, which might be better suited as a young adult. Do you want to give additional anti-diabetic drugs to reduce the need of insulin, so that you really consider this also a first-line treatment? Would you consider a pump in order to no need for carb counting because you have the pump taking care of that? And would you start with blood glucose monitoring because for a child, 8-year-old, it's very difficult to understand the data, and so CGM would again be something for a later date. So please give us your votes here. Okay, so here we have kind of a little bit of a diverse result. The vast majority thinks, well, he needs age-appropriate education. We'll talk about this in a moment, what this really means. And I agree. I do know that many of my colleagues still like premixed insulin. But I have to say that in the guidelines, this is kind of discouraged because we know that there is quite a lot of variability of insulin need from day to day, exercise, intercurrent sicknesses, many reasons, which make it important to adjust the insulin dose to kind of the daily life of a patient with type 1 diabetes. And although I agree, it might save injections, it, on the other hand, is making it more difficult to reach normal glycemia, which is so important for the long-term outcomes, so that the premixed insulin simply doesn't give us this flexibility. And it is actually very difficult for somebody who has been used to a very unflexible regimen to later on change to a more flexible one. Although during the remission phase, during the honeymoon phase, it is quite easy to even use premixed insulin, but it's very difficult to intensify it. So kind of the principle of intensified multiple daily injections that kind of glucose and insulin, need to be related to each other. This is something that you cannot really teach with premixed insulin. And this is why this premixed use is discouraged. Obviously, metformin is not a treatment for type 1 diabetes. Many people have tried it, particularly in those obese people with type 1 diabetes, and obesity is becoming more and more an issue also in type 1 diabetes. But so far, the randomized trials have been very discouraging in this regard. Yes, of course, you need to do carb counting, whether it's a pump or MDI. There's no difference in that, and we actually recommend CGM for everyone from the beginning of type 1 diabetes if it is achievable and affordable. Really, it's the caregivers will look at the data even if the child is not able to look at it, but even particularly in those who are looking at the arrows, the trend arrows, those are things that even children do understand in big numbers and small numbers. So as soon as they're in school, they can actually make some use of it. And many of the CGM systems now have follow-up functions where a caregiver can actually look into it. So to look at this again, the correct answer here would be the appropriate diabetes education. I have a problem with the slide movement right now. And here now we have the age-appropriate education. And this is basically what it is. Just on top, we have to, motivate, of course, the people. We have to find out where is the family, where is the individual child, where is the individual with type 1 diabetes, where is he right now? It takes some time to digest the diagnosis, of course. You have to answer many of the questions that are there. But if you really use simple, complex, gentle steps, particularly some children have a short attention span, you have to tailor it to the age. And in the right box, you see the different issues that we need to follow, that insulin is a life-saving therapy, that you have several things that help them to manage it, like carbohydrate countings, maybe bolus advisors, the role of blood glucose and the glycemic targets are important. And it's very important that everyone in the team agrees on those targets. And we understand that if we look at registries, which centers are particularly successful on average, those are the centers with the most ambitious targets, and in particular where everybody in the team agrees and knows what the target is, so that not I don't know, a nurse on the ward says, it's okay. I mean, if he has good control later as in adult life, that's good enough. You don't need to try very hard right now. This is, of course, very counterproductive and should be avoided. And yes, nutrition, school and diabetes care, management of hypoglycemia, hyperglycemia, exercise, sports, sick day management, all of these things need to be part of the education program. Now, the question was, why a pump? What is really the advantage of a pump? And just here is kind of a quick show how this works. The big advantage of a pump is that you have really this circadian variation. You are able to program the pump in this way. And again, you don't have to inject. You only have to exchange the tubing of the pump every 2 to 3 days. There are some long lasting infusion sets up to 7 days. Our experience was not too good with those. So you have actually less pricking. You have the flexibility of giving pre-meal snacks with the system. So those are the advantages, also particularly for young children, because this is the most flexible type of therapy. If we look at the adults, how this is actually thought here, again, there is very much the same type of education necessary. You see that the adult guidelines also say CGM is preferred. They say everybody should learn blood glucose monitoring for a backup, because always technology can fail. Again, starting the insulin therapy is one of the first things that we need to do, preferably MDI. But the guidelines also say pump therapy or hybrid closed loop technology, we'll come to this later on, can be started based on individual circumstances. It's important, and you see in these guidelines, hyperglycemia is kind of coming before hypoglycemia. In the old days, we have really focused very much on the prevention of hypoglycemia. We understand now that actually hyperglycemia is much more dangerous for the long term, in terms of what long-term complications are, like retinopathy, nephropathy, increased cardiovascular disease, but also cognitive function. And in many years, we always thought that hypoglycemia would lead to poor cognitive function. It's actually the other way around. Hyperglycemia appears to be much more important for this as well. So moving on to the next case, again, 11-year-old prepubertal girl who was first misdiagnosed as having anorexia nervosa. So extreme weight loss. But then a random glucose check revealed a blood glucose of 280 milligrams per deciliter. She has several other family members with type 1 diabetes. She loves physical education. Her laboratory findings are positive ketones, positive glucose in the urine, random blood glucose of 280, and an A1C 7.9, not that high. And the questions now are, which of the following statement is correct? Is it important that children with diabetes should be excused from physical education due to the threat of hypoglycemia? Would you consider that we should always have oral glucose tolerance test? The A1C of 7.0, would you do an oral glucose tolerance test? now she already has a lot of other family members. There are more children in this family. So before the disease manifests itself, should we actually test those siblings with urine glucose testing? And would you consider telling the family that a disappearance of diabetes in childhood, she is not yet in puberty, is that this is possible, and so the family shouldn't be so sad about it, just wait and see? And would you immediately, even in this constellation, start with basal and prandial insulin? So please vote now. Very good. I mean, I've lots of experienced diabetologists. Maybe my questions are really too simple. I congratulate you. Yes, as we already mentioned, insulin should be started with basal and prandial insulin. There is really a myth that diabetes could disappear in puberty. I've not seen a single case. I'm not sure that this is really possible, and I think it's extremely important to really, as soon as you're sure about the diagnosis, that you tell the family this is what it is. We are definite, and diabetes will not go away, even though you might have a honeymoon phase where temporarily the insulin dose can be completely reduced, and there might be even a time of, particularly if it's diagnosed very early in the course of the disease, that you can do without external insulin, but diabetes will come back, and the need for external insulin will come as well. So the answer is prandial and basal insulin, like we have discussed before. We do have a little bit of a difference now. Before, when I started doing diabetes 30 years ago, more or less everyone had type 1. One has to be quite careful nowadays. We know much more about monogenetic forms. So if there are no insulin antibodies, you really have to look into it. And yes, there are some people who have antibodies, but anyhow have type 2 diabetes. So this is also happening. And yes, there is even a description that people with monogenetic diabetes forms sometimes may have one antibody or so. So it's difficult. Of course, you should make your diagnosis. We talked about this earlier. Our options are, of course, that you want to start everyone with a CGM who has type 1 diabetes, either pump or pen. There is no difference between girls and boys. The characteristic is that we have really a fast development of symptoms. So if you are making your diagnosis of type 1 diabetes, you cannot say, come back in a week or so and we'll talk about it, because the child can be in ketoacidosis and DKA just within a week, or within a day, within a night. So whenever you make this diagnosis, the treatment needs to be started. This might be a little bit different in type 2 diabetes. Here we could have some time to look at, how much insulin resistance is there. You might want to do a HOMA index. There are large ethnic differences. There is usually a preponderance of girls. For the monogenic diabetes forms, it really depends on the monogenic diabetes form. This is why it is important actually to make the diagnosis, because there are oral treatments. Many of them have to be treated with insulin, particularly in neonatal diabetes. Again, you would rather want to use a pump or even a closed loop pump. So this is really depends very much on the diagnosis. Now, let's see. So here are the criteria for the diagnosis of diabetes. For the most cases, the classic symptoms and glucose value of 200 milligrams or more than 11.1 millimole is making the diagnosis. You have to be a little bit careful regarding the fasting plasma glucose if this individual is really fasting. But if you have glucose higher than 7 or higher than 126 milligrams per deciliter, again, you should consider the diagnosis. In cases where you're not sure, then you can do an oral glucose tolerance test, but be sure to first also do an A1C. Again, it's not 100% value, so even an A1C below 6.5 doesn't exclude the diagnosis of diabetes. Yeah, it's usually a combination of the clinical signs together with the lab signs. As I mentioned before, and I'm introducing now the concept of the stages of diabetes. What I have told you now, this clinical diagnosis is now considered to be stage 3 diabetes. And the reason, therefore, is that we know that somebody who has more than 2 autoantibodies, even though this individual has no symptoms, he or she will develop type 1 diabetes in the long run. And once you start to have dysglycemia and abnormal blood glucose, in addition to those multiple antibodies, we're talking about stage 2 diabetes, and we'll talk about the options later on that we have for such a case. And so what we have discussed so far is stage 3 diabetes, the clinical diabetes with more than 2 antibodies plus the symptoms of polyuria and polydipsia. And then we have long-standing type 1 diabetes. Some call this now stage 4 diabetes, where there is no more any residual insulin there, and you have kind of the full need for external insulin. To move on, we now move to John. John is a 16-year-old boy who has type 1 diabetes for 5 years, and he is not meeting his treatment goals. He is treated with multiple daily injections. His dose is 1.2 units per kilogram. He has a second general basal analog, in this case degludec, and meal boluses of an ultra-rapid insulin analog, in this case faster aspart. He is using CGM and has a time in range of 40% and a time below range of 2%. His ambulatory glucose profile shows that his glucose is rising in the morning hours, a so-called dawn phenomenon. His current A1C is 8.5. He is captain of his football team, so he loves to do sports. And he asks you, so doctor, what does it mean that I'm having an A1C of 8.5? What is the A1C representing is the average blood glucose concentration of the last 8 to 12 weeks, the last week, the last month, the last hour, or the previous 24 hours. Please vote now. Yes, indeed. So you're very familiar with this. We can easily move on this question, but we need to look a little bit closer in the case because there were some things that we haven't so far talked about, and those are the limitations of the A1C. We have for many years used the A1C because it really is a good biomarker for your long-term outcomes, but it doesn't really help to guide glycemic treatment with using the A1C. For many years, we have A1C, but the results are still not very promising, in particular because the A1C does not identify hypoglycemia or glucose variability. In addition, there are problems with the A1C because it might be wrong, much lower than it should be when you have hemoglobinopathies, if you have iron deficiency anemia, if you have transfusions, CKD liver disease, and individual changes of the red blood cell lifespan, and even some unknown factors that we haven't really identified so far that affect glycation or race. Those play a role in the A1C. So clearly the A1C is not telling us the full story of glucose control. And so it's important that we have new parameters, and this parameter would be time and range. And so we would actually say, well, yes, your A1C 8.5 is high, but what is really helping us to guide your therapy is the time and range. And this is the time between 70 to 180. We learned in the case he has 40%. We'll talk about this, how this is, but we always have to relate not only the time and range, but also using the time below range at the same time, because that tells you the amount of hypoglycemia. And of course, we have to balance hypoglycemia and time and range. And to make it easy for the patient to say, some people say, well, if you look at your curve, what we want to have, it should be flat, narrow, and in range. So you want to have as much as possible FNIR days. So flat, narrow, in range. On the left top column, you see this ambulatory glucose profile is neither flat nor narrow nor in range. On the right side, well, it's pretty flat now, but it's still not narrow and it's not in range. On the lower left, you see it is flat and narrow, but not in range. And in the lower right side, you can say, well, this looks great. This is what we want to have, flat, narrow, in range, but it's not easy to get there. Okay, now let's have a look at Robert. Robert is a young man who has been diagnosed with type 1 diabetes 2 years ago. He's treated with multiple daily injections. His weight is 70 kilos. He has 20 units of a first-generation basal analog, Glargine, in the evening, plus 3 times daily pre-meal ultra-rapid insulin, faster aspart with a pre-meal dose of, we calculate everything together, 40 units per day. However, after participating in a football game in the afternoon, he had a severe hypoglycemia with convulsions in the middle of the night. His wife didn't know what to do. So she had to call an ambulance. They gave 20% glucose infusion, and then he regained the consciousness on the way to the hospital in the ambulance and was admitted to the hospital. So what do we have in this case here? What we should have considered for this young man regarding the prevention and treatment of hypoglycemia. Should we have considered nasal glucagon is this as effective as intramuscular glucagon, and can we actually give it safely? Is this a good idea as a treatment of severe hypoglycemia? Should we have told him that he should have increased his basal insulin to reduce the risk for nighttime hypoglycemia after exercise? Would we simply say, well, now that this severe hypoglycemia has occurred, it is very important that we now finally should prescribe him glucagon. It's only necessary to do so if there has been actually severe hypoglycemia, not before. Should we have told him, there is Diet Coke, Coke Zero, those are the sweet drinks which are recommended for people with diabetes, you should have taken that? Or would you consider, well, young chap, you have missed too many prandial boluses, and this is really related to severe hypoglycemia? So please vote now. Okay, so here we have a little bit differing opinions. The majority thinks nasal glucagon is a good idea and is just as good as intramuscular glucagon. But some people say, well, glucagon should only be prescribed when there is a severe hypoglycemia. We shouldn't give it to everyone on insulin. And missing prandial boluses frequently related to severe hypoglycemia. Well, it could be because very often severe hypoglycemia is related to I would say a pure, not so well education, a bad self feeling of how you're doing, and not really looking at the signs of low glucose or high glucose, and not taking good care of your diabetes. And this is basically what missed prandial bolus is also doing. So let's take a closer look at hypoglycemia and the nasal glucagon. And here on the right side, you see the available forms for hypoglycemia treatment. And in our experience, when available, we give all our patients with type 1 diabetes from the onset of diabetes nasal glucagon because it's available in our country. Prior to the availability of that, we gave everyone Glucagon, there are now stable glucagons like dasiglucagon or Gvoke. There is the lyophilized powder, which is also approved for actually for all ages. For the other glucagons, there are restrictions in terms of the age restriction for the prescription of the glucagon. But clearly, very, very important, if this is happening, is the individual still conscious and able to swallow? Then you would give him fast-acting carbohydrate, of course, no Diet Coke, that is clear. So, but yes, you could use the normal Coke. You could use apple juice, orange juice, something like that. But it is important to make sure that this is an emergency situation and shouldn't be provoked to be able to eat all kinds of sugar things, because it is hypoglycemia is a medical issue and shouldn't be kind of misused in families for additional snacks or things like that. If somebody is, of course, unconscious, unable to swallow, then you need to administer glucagon. And as I told you, there is just one dose in the intranasal glucagon. There's no way to dose it, but it can be used safely from age 4. And otherwise, you can give the glucagon subcutaneously or intramuscular. If you are in a hospital setting or like the paramedics we saw in the case, you can give 10% glucose. This is maybe a little bit more less problematic if you don't have a good vasal setting of your infusion set. So 10% might be better than in the case that the 20% to administer that. We move on to now a 25-year-old young man who has been diagnosed for type 1 diabetes for quite some time. He is using a sensor-augmented insulin pump with predictive low glucose suspend. His time in range is 50%, time below is 3%, A1C is 7.5, but he is still not happy with his glucose control and wishes to change to an automated insulin delivery device, which is covered by his insurance, and he asks you if this is indicated. So I wonder what you think now is, in order to avoid misconceptions of the treatment with a hybrid closed loop system, something like automated insulin delivery, you want to first tell him certain things and make sure that he understands this. One of the things he needs to know that on average, there is no difference between the time and range achieved with AID compared to multiple injections. Do you want to tell him that estimating the meal size is not important with the automated insulin delivery device? Would you tell him, well, there are actually two things in this device. It's in the commercially available AID systems, you use insulin and glucagon infusion. Would you tell him a mealtime bolus should always be taken before a meal with AID? And would you tell him a DKA cannot happen with AID because that's, of course, the way that the automated insulin delivery works? So please vote now on case number 7. Okay, now here we are discussing a little bit. On average, there's no difference between the time and range with MDI and AID. I'll show you in a moment. This is not true. Actually, we have to say that there's good evidence now that the automated insulin delivery device in the majority of patients is reaching better outcomes than with the multiple daily injections. Of course, estimating the meal size is also important. We'll discuss this in more depth in a moment. Yes, there are experiments with insulin and glucagon infusion, and in the recent ESD meeting, the Dutch group has actually shown this, that it was able to work, that using insulin and glucagon and this would be a full closed loop system, but we have to see whether this ever will go through a regulatory approval. And of course, it's quite cumbersome. They had to have 2 sensors plus 2 tubings, and they have to exchange the glucagon every day. So that's quite a burden, but of course, this would be a full closed loop system. A mealtime bolus should always be taken for the meal with AID, the right answer. You got this right. And of course, you have an infusion set, and any infusion set can fail. And so if you are not actually be quickly understanding that here might be infusion set failure, the AID can't help you because the insulin is not going into the body. So the typical things you need to know with pump therapy, you also have to know with AID, like infusion set failure and the risk of DKA. So the correct answer here is that we have to have mealtime boluses. And again, it is important to look at the glycemic targets. This is what this young adult was unhappy with. So you can use the CGM targets here. Is we are recommending more than 70% time in range. Usually this kind of is very close to what we know from the famous DCCT trial, which tells us that 7% or even less should be achieved in or below 53 millimoles per mole. That this is kind of the target for the A1C, and well, less and less we are using the finger stick glucose. And interestingly, if we look at the adult guidelines, they actually say intensify the injection therapy if you are on a less intensive regimen, if you are not meeting those goals. But if person is already on injection therapy and an appropriate candidate, switch to pump or hybrid closed loop technology is recommended. So clearly this would be the case of this person that we have just talked about. And just to refresh your memory, obviously such a closed loop system, it needs a glucose sensor, needs an insulin pump. This can be a patch pump or a tethered pump. And then the algorithm is either on a cell phone or a dosing device or on the patch pump or in the pump, and is getting the glucose sensor data, then calculates the insulin infusion. But these systems, of course, do not know when somebody is eating or doesn't know when somebody is exercising. So all of this information has to be put into the pump system. And why is it still important to actually do the pre-bolusing? And here is, apologies that it's in German, but you can understand there is the times of days is here. And here you see that he is taking a prandial bolus, but is quite low. So those pink lines show that there's more and more insulin given automatically, the basal insulin. So the next time he is actually, or she is eating a meal without a prandial bolus, because you don't see this little blue line for the bolus. Again, there's lots of pink. So the automated insulin delivery is giving a lot of insulin. Then the individual sees, oh, my glucose is high, and actually gives quite late a prandial bolus, but doesn't take into account that the pump already has corrected the high glucose value. So if you then give the full bolus amount, of course, the biggest risk that you can get is hypoglycemia, and this is what is happening. The pump, as you can see, sharply stops the insulin infusion, cuts off the insulin, but you cannot pull out any insulin at this point. So there is a hypoglycemia, although there is basal suspend. So the preprandial giving of insulin is also important in automated insulin delivery. It's not, foolproof that, you don't have to do anything anymore. Hypoglycemia can happen if you don't adjust if you have a late bolus, and I guess this is one of the most difficult things in automated insulin delivery. So if possible, always give a preprandial mealtime bolus. In case of postprandial bolus, reduce the bolus by half. Now, he also, or there's somebody else who has also using a predictive low glucose suspend. And what really causes him a lot of problems are the alarms. So it wakes him and the family several times per week in the middle of the night. And what would we do here? He is using a sensor augmented pump. He has time in range of 50. He has time below range of 3%. His A1C is 7.5. What do we tell him? Shall we tell him low glucose suspend are the best that are available? Shall we tell him an A1C of 7.5 is pretty good for somebody his age? Should we tell him on average AID pumps also achieve a time in range of 50% or less? Should we tell him that increasing the time in range further with an AID will increase his risk for hypoglycemia as well? He needs to be aware of that. And should we tell him, well, it's quite correct. Many people with type 1 diabetes report a better nighttime sleep with AID. So what do you think? Okay, now here we are quite diverse. Low glucose are the best that are available. Well, this depends on your country, but as far as I know, in your area, automated insulin delivery devices with both low glucose suspend plus automated insulin correction doses are available. So this would be not the correct answer. We considered an A1C below 7% and not 7.5 anymore as the target. So even in the young children, even a lower target. We consider that increasing the time in range usually with an AID does not increase the time in hypoglycemia. And yes, indeed, many people with type 1 diabetes report a better nighttime sleep with the AID. So the correct answer in this case would be that many people with type 1 diabetes report a better nighttime sleep. And I think in all truth, you can actually tell people one thing for sure. It might be difficult during the day because carb counting is still necessary, the adjustment of exercise and so on. But really, most systems give you a very good result overnight, and you have a better nighttime sleep. Here is just a picture how these systems actually work, what the difference is between sensor pump therapy, which does not have any automation, then the low glucose suspend, which only has a threshold reduction of the glucose. So at a certain threshold, it cuts off the glucose infusion. The next step was the predictive low glucose suspend, where actually the glucose is still in the normal range, but the insulin infusion is already turned off. And what we are having now is that the system adjusts the insulin delivery through the pump. It requires mealtime boluses input, but actually is giving correction boluses as well, and is giving a flexible basal insulin. And clearly, I mean, if you take a look here, how different the nighttime glucose infusion is from one night to another. This clearly shows you that it's difficult to do so with MDI therapy. And also what we have seen before, there are quite big differences between average glucose control in the different age groups in different countries. And we always kind of envy the Swedish people because they have such good results, while the UK people are not quite as good. But you see on the right side, the average values, the time in range with an AID system, and there are no more big differences between different countries. And there's also, interestingly, no big differences between different age groups and so on. So really the AID systems somehow are diminishing the differences that we have seen before. And you see that on average in all countries, they are reaching 70-75% time in range. So quite a lot more than before with AID. Okay, next case, we need to speed up a little bit here. Again, somebody who is not meeting his treatment goals. I think we had him before. I think I just want to tell you that he asked about the ambulatory glucose profile, which he wants to use to improve his treatment. And so the question is, what is the ambulatory glucose profile? Does it show me the median glucose over the 24 hours? Does it reflect the glycemic control of the last year? Does it help me to assess the risk of retinopathy? Can it be calculated from a single day of CGM measurement? And is it identical for two patients with the same A1C? Please vote now. Yes, well, there are really two groups here. One says it shows the median glucose over 24 hours. This would be the correct answer. You cannot have it from one single day of measurement because it's kind of the median. So you need to have, in the consensus group, we are recommending 14 days actually of CGM to make a good assessment of the glucose control. So here the right answer would actually be, shows a median over glucose of 24 hours. And I've brought you now here three profiles of an average A1C of 6.7. You see that the glycemic variability here is 53%, quite a lot of glycemic variability. The same A1C, 6.7, less glycemic variability, but a completely different profile in the ambulatory profile. And then the third one here, the coefficient of variation is very low. There's low glycemic variability. And again, the same average A1C, which shows you really the difference between the ambulatory glucose profile, which gives you an impression what to do and what to change. And the A1C doesn't really tell you. This is why the CGM is so important. And the A1C doesn't really help you, because in these three different profiles, you would probably give a completely different advice to John, depending on looking at his glycemic profile here. Now, if John is very afraid of hypoglycemia and wants some guidance, which value in the CGM would be considered as clinical relevant hypoglycemia? So let's move on to this question here. Clinically relevant hypoglycemia level 2 in CGM analysis, would this be below 80, below 100, below 54, below 90, or below 75? Please vote now. Very good. Indeed, it is below 54. And I'll show you the reason why in a moment. Below 70 would be level 1 hypoglycemia. And here you see the different ways that we're calculating it from the CGM values. So we have the time in range, which is usually 70 to 180, 3.9 to 10 millimoles. Below 70, below 3.9 millimoles is the level 1 hypoglycemia. Level 2 would be the clinically relevant, below 54, below 3. So we would tell John, well, yes, you will have some values below 70 because if you are close to normal glycemia, this will happen. We don't want it to be more than 4%, but sometimes it will happen. A value below 54 is clinically relevant. So we should really look into this, why this is happening. We want to avoid it. Less than 14 minutes per day could be okay under some circumstances, but this is certainly something you want to avoid. And on the other hand, if we look from one time in range to another, if you have 5% change, this is what we would consider clinically relevant. Now, finally, John asks us, is it okay that I aim at a higher A1C because hypoglycemia is really my big problem, and I don't want to have a hypoglycemia. Is this a good idea? And so when we talk about his conceptions of hypoglycemia, what is wrong? So now you have to tell him this is wrong. Is it correct to say it is related to self-awareness? Is it correct to say it is independent of A1C? Is it correct to say that hypoglycemia is a concern when reaching near normal glycemia? Is it correct to say hypoglycemia is related to diabetes education? And can we say it does not happen when the A1C is 7 and above? What is the wrong answer? I know it's always difficult with those negative ones. Okay, so 60% say the wrong answer is it does not happen when the A1C is 7 and above, and you are quite correct. It is really something about self-awareness. It's something we can actually educate. So better education reduces the risk of hypoglycemia. It is true that it is a concern when reaching normal glycemia, because the closer you are to normal, the more risk you have. It's not independent of A1C, because yes, it does. The DCCD has shown us that, but we can do something about it, and we'll talk about this now in a moment. So the correct answer here is it is wrong that an A1C doesn't happen when the A1C is above 7. So it's not a good idea to say, let's aim at a higher A1C to avoid hypoglycemia. And this idea of, increasing the A1C in order to prevent hypoglycemia comes from the DCCT trial, which is, of course, a landmark trial. It's great because it has shown us it's important to have good control. But the misconception was that we have to balance it with hypoglycemia. And clearly there is now plenty of data, and I'll show you some registry data from the German registry, which shows you that there is no more, when we have good education, we can lower the risk of hypoglycemia in all groups of A1C through education, teaching self-awareness. And so we should discourage John to aim at a higher A1C in order to avoid hypoglycemia. Now, finally, we have convinced John that he wants to have a change from multiple daily injections to an automated insulin delivery device, and wants to complement his CGM device. And again, there are now new treatment principles. And I apologize again. We are looking for the negative one, which is not true, because I want to. Many of the things are true in the way that we are managing it. So, is the adjustment of carbohydrate ratio is still important? Is it not true that the timing of the user-initiated bolus prior to carbohydrate intake is less important? Should we, for ketones, switch to manual mode? Do we advise fewer carbohydrates are needed during hypoglycemia? And the handling of missed meal boluses need to be changed. So there's only one thing of those 5 things that is not true, and this is what we are looking at. Okay, so this is now getting difficult, but it's very good. The majority picked the right one. The timing of the user-initiated bolus is very important. We have seen this previously in the example I've showed you. If you're too late with your bolus, you might have a problem. Ketones is, some people say, well, you can go on with the ketones, also with AID. Others recommend switching to the manual mode. Very important, the rescue carbohydrates are needed less, and the adjustment of insulin carb ratio is important for many people. So here, the correct answer is the timing of the user-initiated bolus. And here you can see how this is actually working. So we have the change in the basal rate, you have the automated correction bolus, and here we have an individual who, although the system already gave more insulin, he gave a late bolus, and this then led to hypoglycemia, although the system had turned off the glucose. Now, a completely different story. Maria, she has diabetes for 5 years. She has been vomiting now and is coming with vomiting in the emergency room. She first had pretty good control. Lately, it's a little bit difficult. She is overweight. She has a high body mass index. Her most recent A1C was clearly not in the good range, 9%, 75 millimoles per mole. She never had an episode of DKA. and she is complaining of severe abdominal pain. She's very dehydrated, and the emergency room nurse says, let's call the pediatric surgeons. This might be acute appendicitis. Well, you as an experienced team know that she might have a pediatric DKA. What is typical what is not a typical sign? Is it the abdominal symptoms that she have? Is it the deep breathing that she has? Would it be fever? Would it be the dehydration? Would it be vomiting? So what is not a typical sign of pediatric DKA? Correct. So fever would not be the typical Kussmaul breathing, is the breathing of DKA. And clearly fever would be the wrong answer here. We really have to teach all the healthcare professionals that they ask the right questions when this is happening. Is there bedwetting again? Is there nocturnal bedwetting? Actually, in some areas, one could actually, are there ants in the site of urination? Is there unexplained weight loss? And if there's any of those is yes, then just measure ketones, so important, and avoid that somebody is misdiagnosed. So before Maria can be transferred to the intensive care room, the staff want to start the therapy. So what do? Do they change the infusion set of the pump? Do they give her intravenous fluids? Do they give her intravenous glucagon, intravenous bicarbonate, or subcutaneous insulin bolus? What would they do? Please vote. Very good. So absolutely great. Some people would like to give insulin, but really the first step is intravenous fluids, and she's still in the emergency room, so you can wait a little bit for an hour with subcutaneous insulin, and intravenous insulin is actually the better choice. So here the right answer is the intravenous fluids. And here you see the guidelines, very important. I'm very glad that none of you has suggested bicarbonate, because that's one of the biggest mistakes that is usually been done, that they say, oh, it's acidosis, so we need to get bicarbonate. But this is not the right thing, because it's causing liquor acidosis, and so because the bicarbonate does not go into the liquid, so we shouldn't do that. Now Maria is transferred to the intensive care unit. The parents are very worried what the cause of the DKA actually was, and so what do you think is the most common cause? Is it the insulin omission? Is it the overeating of carbohydrates? Is it over-insulinization? Is it the pubertal growth spurt, or is it using the wrong pump insulin? What do you think? Absolutely correct. I agree, and there is a misconception. So many people think that overeating is really an issue. If you have enough insulin, you can eat as much as you want. You won't have a DKA. It's really the lack of insulin that is causing the problem. And so insulin omission is the most frequent reason. Of course, insulin omission can also be kind of a relative one, so that the dose is not enough, or you actually I have an intercurrent illness which would have much higher insulin needs, but really insulin, a lack of insulin is the most important one. So as Maria now arrives in the intensive care unit, the laboratory values arrive and need interpretation. We take a look at the values here. They what would be in agreement with the case, which would be typical. Is it the base excess being normal, a beta-hydroxybutyrate of 3.0 millimoles, an A1C of 5, a pH of 3.5, and or negative ketones? What do you think? Very good. Excellent. Yes, the beta-hydroxybutyrate is the issue where we would consider that this is typical for a DKA. Here you see again the different levels, because in some places it is possible to have actually finger sticks for ketones, for beta-hydroxybutyrate, which is very helpful to diagnose a DKA early on. Some other people are using urine ketone levels, which are also not too bad. Now, here we have another.
I think,
yes,
Prof, we should stop here and take questions. I mean, we might ask these questions.
That's okay. Very good.
So Thank you
Please
so
go
much. This is an excellent, but to take questions, so we will do that.
Absolutely,
Actually,
so
it
important.
was really excellent.
Thank you.
And I noticed that the group scored high. Myself, I scored high. So this is really
An expert group.
assuring. Yeah.
Thank you.
Please, if you have questions, please put them in the queue. I will start by a few questions. How often could type 1 diabetes be antibodies negative? How often that could happen?
Yeah, a very good question. And indeed, there are approximately 95% have antibodies, so 5% in some cases, even up to 10%, there are negative antibodies. It's very difficult to say whether those are negative antibodies during the whole course of type 1 diabetes. So if the individual never had antibodies, as the antibodies are not the thing that are destroying the beta cell. So it's kind of just a sign of a stressed beta cell.
Good. How often do we screen for celiac disease, hypothyroidism, adrenal?
Yeah, so there has been a big controversy, or it's still ongoing. Shall we screen for celiac disease if there are no symptoms of celiac disease at all? We personally, we do it in our place. We screen every 1 to 2 years for celiac disease antibodies, and do the same for thyroid antibodies, because autoimmune thyroiditis is present in 15%, so we should do that.
Now I have a question here. In type 1 diabetes, patient on MDI will run marathon. What is the best approach to his insulin regimen?
Okay, so to my knowledge, there are of course some marathon runners which are using an insulin pump, but the majority that I know of these extreme athletes are actually using a shot of basal insulin, first generation basal insulin analog, and then they have different glucose drinks which they drink at several times, and give themselves ultra rapid insulin when their glucose is increasing. So this is one of the most challenging things to do, but it can be done.
Another question here: is there any role for rectal glucose for correcting hypoglycemia?
I don't think so, because the rectal glucose is not really reliable. I would not consider doing that. So if you don't have glucagon, if you don't have intravenous glucose, the best thing to do is to take a glucose tablet and just put it into the buccal space if you're unable to have a glucose infusion.
Okay, so with fast correction of diabetes and correcting A1C, would it cause or worsen diabetic retinopathy?
A very, very good question. So yes, indeed. So a quick correction could worsen retinopathy. On the other hand, if you're too slow, this of course is also leading to a progression of retinopathy. And so the studies that I'm familiar with recommend, yes, we should improve glycemic control, because in the long run, if you follow up those people, the improvement of the glucose control in the end pays off. But yes, there are cases where a rapid decreasing of glucose might actually lead to a worsening of retinopathy.
What's your experience with the treatment and cure of type 1 diabetes using the teplizumab?
Yes. So this was my last case, basically. So we know that a course of 14 days teplizumab in stage 2 diabetes is leading on average of 2.7 years of a delay. There has been up to 10 years delay, but of course 2.7 years is just an average, so it works not in everyone. But the studies have led to an FDA approval for stage 2 diabetes. We still need to figure out, who is really responding best with teplizumab, and whether a second dose after 6 months or so is necessary or not. My personal feeling is probably not, because many people are developing anti-teplizumab antibodies. So I guess in the end of the day, we need personalized medicine, find out who is really the best person. But if it would be available in Germany, and which it is right now, it is not yet, and I would have a person with stage 2, I would actually recommend teplizumab, yes.
Yes. Now, we know it's not approved. Would you use SGLT2 inhibitors? I know you like this area here. In type 1 diabetes with congestive heart failure or cardiac patients with type 1 diabetes?
Absolutely. I think clearly SGLT2 inhibitors are very effective in reducing your cardiovascular risk. It's also reducing glycemic variability. My hope is that when we would have something as safe like a ketone sensor, which is going to come in the not too distant future, and this would ameliorate the problem of DKA, which is, of course, much higher in type 1 diabetes and SGLT2 inhibitors, this will become a good treatment again. So if you have a very good patient who is very sure that he or she will not go into DKA because she has blood ketone meters, she knows what the signs and symptoms are, it's off-label.
So for the board examination, would you use a GLP-1?
No, for the board examination, no.
No. How about GLP-1 agonist?
Again, no, it's not approved in type 1 diabetes.
So you do not use it in the exam. However, in real practice, we might, which we all are doing, yes. How about metformin? You answered metformin. No. Okay. Any more questions here? How could exercise worsen hyperglycemia?
Well, this is an interesting point. So particularly if you have a short exercise with a lot of muscle power, there is a release of glucose from your muscle. And so if you don't have a lot of insulin in your body, which is good when you want to do exercise, so if you have actually a short sprint, your glucose goes up. So there are some people who are actually using a short sprint if their glucose is low and they want to have a quick increase of their glucose. So some athletes complain that when, or not complain, but show that when they have a high action sport, their glucose initially goes up before it goes down.
So at what level of blood glucose, low or high, you will advise your patients, type 1 patients, not to exercise? At what levels?
So clearly when somebody has more than 300, this is or more than 250, this is a sign of insulin, lack of insulin. And this would then, if you exercise, increase your ketones and the risk of DKA. In this case, I would consider, please don't exercise. Everything else, low values. I have had sprinters who go sprinting even with 60, but this is nothing I would say in an exam. So here I would say, if somebody has 80 or less, I would say first eat carbohydrates before you exercise.
Right. What time is the best to exercise if you have type 1 diabetes? What time? Is it in the morning, afternoon? What time is better?
Well, the biggest issue here is the nighttime hypoglycemia. So we know that the insulin sensitivity is improved for 4 to 6 hours. And so depending on the length and the strength of the exercise, so it is better to do this during the day, because that's a time where you can look at the results of your glucose more easily than in the night. So having heavy exercise at night might be more difficult, but it depends on the type of therapy. If you have a glucose sensor, of course, with alarms, then you're pretty safe. But during the day is better than before going to sleep.
Okay. Now I have a question here. Type 1 diabetic with gastroparesis. They have high blood glucose, then followed by hypo. So how would you correct this? I mean, if there is no insulin pump, not possible for this patient, how would you correct this?
Yeah, this is really one of the most difficult issues. Try to have several small meals instead of big meals, to have this dumping problem, not so much. Gastroparesis is one of the biggest challenges in diabetes.
What is the best and fastest absorption of insulin?
Well, the ultra rapid analogs, there are two, faster aspart and treprostinil lispro. Those are the ones which are commercially available and the fastest insulins so far. And of course, you can by massaging the site of injection and the injection site, choosing the abdomen has the fastest absorption. Those are things that you can do.
Okay, all right. That's very clear. They say that with new onset type 1 diabetes, a very low carbohydrate diet might help. Is that possible?
Well,
For
this
recovery
is
and I don't know, delay.
so the low carb diet is very popular in many social media posts. Clearly, you have less glycemic variability with a low carb diet, but on the other hand, it's not easy to follow, particularly for children. And number two, you need carbs for to thrive and to grow. So you don't want to end up in a situation where the low carb diet is leading to somebody who is then not growing well and so on. So this might be something to be tried out for adults and not so much for children.
Do you have any limitations on the duration of exercise for children with type 1 diabetes?
No. I have children who are in competitive sports, and so I don't have any limitations here, no.
And how soon after exercise would you check the blood glucose?
Actually, I would check also during the exercise. So the biggest problem is actually after the exercise very often. Because the people do not understand that this improved insulin sensitivity, depending on the duration of the exercise, can last as much as 6 hours after the exercise. And you can, in an automated insulin delivery pump, you should be in the exercise mode well above, after the exercise and already 1 to 2 hours before the exercise, because you want to start the exercise with the lowest possible insulin level.
Right, so you reduce the basal insulin about 6 hours. I mean, from the start till the end of exercise.
Correct.
Okay, very good. And again, the same question about GLP and obese type 1 patients.
It's
off-label.
Presently, it's off-label. I sympathize with the idea of doing this, but the studies have shown with liraglutide that there was increase in hypoglycemia, and this is why those studies were then stopped, and it was not tried to get it into the label. But I think it's not the end of the story.
Well, I think it's time to finish here. I have no more questions. There is one. When do we recommend twice daily basal insulin? That's good.
When do I twice daily?
Basal insulin,
insulin
twice daily.
Actually, only with NPH insulin, which is allows you to tailor your insulin very, very nice. So you can even give it up to 3 times a day as a basal insulin, but it always has the problem of a very strong action 4 to 6 hours after the injection. And the second generation analogs or the first generation analogs, I usually give just once a day. Some people take the first generation twice a day, but we are kind of fans of once a day.
Okay. Yeah, we're given enlarging twice daily, but that's rare when we have a very high dose of insulin.
Yeah.
Any more questions here? I see no more questions. This was really an excellent session. Thank you so much, Prof. Dunn. And I also would like to thank all the audience for attending for about 7 hours in a row.
Oh my goodness.
Thank you very much. And we will see you tomorrow at 5 p.m. Saudi time. Assalamu alaikum. Good night. Thank you very much. Thank you, Professor Dunn, again. Excellent session. Thank you.